Hello, good evening, afternoon, and morning. My name is Anil Mandal. It's a pleasure to welcome you all to the virtual conference of the Indian Pediatric Glaucoma Society. We are grateful to all members of the organizing committee who have put together such a beautiful program. We have 4 keynote speakers, challenging cases, 3 papers, and a plenary session on action field rigor anomaly. I wholeheartedly welcome all the delegates who have joined this webinar today. Thank you. Over to you, Vinay.
Thank you, sir. We are delighted to have this session on pediatric glaucoma today, and I must admit that as president of the society, I'm very happy to say we have more than 300 registrations for this meeting. We have almost delegates from 60 countries around the world, and given for a young society like ours, I think it's a big achievement. So the idea behind all of this is that we are all able to improve the lives of the children of glaucoma that we are dealing with. I must tell you that this session is basically a learning experience. If any of you are interested in putting up questions, we have a question link which you can use to put in your questions. You can also use this Yahoo mail ID of the IPGS if there are some questions you think are unanswered and you want to have some questions or suggestions to give regarding our meeting. Our next meeting after this would be hopefully physical, and it should happen in Delhi, and we would inform you about our meeting. So apart from the keynote speakers in this session, I also have a privilege to introduce our other speakers who are also extremely prominent. We have, to begin with, in order of presentation, Dr. Sirisha from LV Prasad Eye Institution. LV Prasad is doing great work in pediatric glaucoma, and Dr. Sirisha is spearheading some of the great surgical innovations in pediatric glaucoma there. She joined LVPI in 2007, and she manages a lot of refractory adult and pediatric glaucomas. She has numerous publications, as well as having received a lot of awards in a lot of conferences, including the American Academy of Ophthalmology. We have Dr. Sushmita Kaushik with us, who is also a prominent pediatric glaucoma specialist. She is the secretary of our society. She has also been the secretary of the Glaucoma Society of India. She has more than 170 publications to her credit and is a recipient of numerous awards and honors. She works extremely hard and has done a lot of work for the Indian Pediatric Glaucoma Society. We have Dr. Sunita Dubey from the Shroff Eye Center in New Delhi. Dr. Sunita has done her glaucoma fellowship at the Wills Eye Hospital. She has extensive experience in managing a lot of pediatric as well as refractory secondary glaucomas. She has numerous publications and has a number of administrative posts to her credit, apart from being a member of the glaucoma task force. Then we have Dr. George Puthuran from Arvind Eye Institution in Madurai. Dr. George has graduated from the Government Medical College in the South, and he has a number of publications dealing with the ADI, which is the low-cost glaucoma drainage device, which the Arvind Eye Care System has brought out. He has a number of publications and has a lot of experience in the use of ADI, which he will be discussing in his talks. Dr. Gauri Murthy is from the Prabha Eye Clinic in Bangalore, and she heads the glaucoma services there. She too has a lot of publications and has extensive experience in managing refractory glaucomas. She has a number of recipient awards to her credit, apart from the fact she is also spearheading something which is very novel, which is the Nayana project, which takes ophthalmologists to remote parts of Karnataka, which is a state in South India, and helps them with their glaucoma and diabetes. So this is something very novel which Gauri has initiated, and all credit must go to her for a lot of other innovations too. We have then among our free paper speakers, we have Dr. Karthikeyan Mahalingam from the RP Center in AIIMS, New Delhi. Karthikeyan is working as a fellow in glaucoma, has a large number of publications and awards, along with the fact that he has a primary interest in pediatric glaucoma. Dr. Bindu also is from AIIMS, New Delhi. She works in the genetic epidemiological unit and has a lot of experience in dealing with genetic studies in pediatric glaucomas. She has a number of awards and publications to her credit. Dr. Shikha Gupta is an associate professor, again at RP Center, AIIMS, New Delhi. She has co-authored more than 130 review papers. She has research awards, which are so many that I can hardly count or talk about them. But then I must say that she's another hardworking person who has spearheaded pediatric glaucoma at RP Center. We have another free paper speaker, Dr. Venkatesh Nathia, who is also from RP Center in AIIMS, New Delhi. He represents a young, budding fellow who is primarily interested in anterior segment surgery. He has been a topper of MD ophthalmology exam, and his research thesis was to compare the corneal characteristics in eyes of primary congenital glaucoma versus those with Axenfeld-Rieger syndrome. We then have our next speaker of this, I don't know, it's not going down, is Dr. Dr. Sandeep Chaudhary, who is from PGI Chandigarh. Dr. Sandeep Chaudhary is also doing his senior residency in the glaucoma subspecialty with a special interest in clinical genetics of glaucoma. We have from the Bascom Palmer Eye Institute, Dr. Raquel Quintiniala, who's also a fellow from the Bascom Palmer. She's a medical graduate from Peru, and her work currently revolves around pediatric glaucoma at the Bascom Palmer Eye Institute. That is me. I will also be taking up a talk in the session that deals with in the third session that deals with recent literature from India. I'm the president of the Indian Pediatric Glaucoma Society. We have Dr. Devang from AIIMS, New Delhi. Dr. Devang is an anterior segment surgeon, also doing a lot of pediatric glaucoma. She has more than 80 reviewed research papers to her credit, apart from the fact that she has received a number of awards for her glaucoma research at the All India Institute of Medical Sciences, New Delhi. We have Dr. Vijaya from Gotwal from LV Prasad Eye Institute. Dr. Vijaya has done remarkable work in rehabilitating a lot of patients who are end-stage glaucoma. It is an establishment that is worth watching. Probably the only such institute or center in the country that deals with rehabilitation of children with glaucoma, apart from the fact that she has more than 100 peer-reviewed papers to her credit. Day two speakers, we will have some clinical challenges presented by Dr. Harsha Kadawa from LV Prasad, from Ashok Kumar from PGI, Julie from Shroff's Eye Center, Dr. Monica from AIIMS New Delhi. We have Dr. Kirsten De Silva also from the Bascom Palmer Eye Institute presenting one of the clinical challenges. So this is a brief introduction to our speakers, and over to you, Dr. Mandal. We will start with our first keynote lecture, which will be delivered by Dr. John Brooks. Thank you.
Thank you, Vinay. It's my pleasure to introduce the first keynote speaker of the day, John Brooks. Dr. John Brooks is a consultant ophthalmologist at the Moorfields Eye Hospital and Great Ormond Street Hospital for Children since 2004. His research interests are on surgical technique and outcomes of different pediatric glaucomas. He was a volunteer for faculty Orbis with programs completed in China, Mongolia, India, Vietnam, and Bangladesh. He is a member of UK Pediatric Glaucoma Society, board member. So welcome, Dr. Brooks. Over to you for your keynote address. Thank you.
Thank you very much for the opportunity to speak at this Pediatric Glaucoma Society meeting in this session, New Surgical Options in Pediatric Glaucoma. I'm going to talk about the procedure that has become my first-line treatment in primary congenital glaucoma and increasingly in some types of secondary glaucoma. It's not a particularly new procedure and has been described for several years now. But I think in the history of pediatric glaucoma, which historically has progressed fairly slowly from goniotomies, which were described in 1942, the 360-degree trabeculotomy is a relatively new type of operation that we now use with great effect. You'll all know the classification system of childhood glaucoma, and I put up this slide really just to point out that the types of glaucoma that respond best to 360-degree trabeculotomy are the primary childhood glaucomas, primary congenital glaucoma, and juvenile open-angle glaucoma. Increasingly, because of the success that we've had in treating primary glaucomas, we've also started using this in some secondary glaucomas as well. And like all procedures, the outcomes are not quite as good as with PCG, but if it avoids children having to have further surgery, such as trabeculectomies and glaucoma tube implants, then it's well worthwhile considering this as an initial surgical therapy. We all know that glaucoma surgery in children is much more challenging, with a higher failure rate and a higher complication rate than adult glaucoma surgery. With our traditional incisional surgery, such as trabeculectomies and tube surgery, we all fear the complications that can happen, such as bleb leaks, bleb infections, and tube erosions and tube-related infections. And the benefit of angle surgery is that we're opening up the natural drainage pathway of the eye without the use of anti-scarring agents, without leaving any foreign material inside the eye. And the procedure of choice depends a little bit on corneal clarity and surgeon's preference and experience. Traditionally, angle surgery has been done in the form of goniotomies when there's been a clear cornea, and trabeculotomy, traditional trabeculotomy, when there's been corneal scarring or corneal opacity. And as I mentioned before, the success rates for secondary childhood glaucomas are not as good as the outcomes in primary congenital glaucoma. When we think about glaucoma surgery in children, what do we need to avoid? I think increasingly I get more worried about using multiple general anaesthetics in children, because I think there is some evidence that multiple anaesthetics can have some effect on development, particularly in younger children. I also want to try and avoid anti-scarring agents, because when you see eyes that have had anti-scarring agents in years gone by, this can have a very detrimental effect on the conjunctiva with avascularity, thinning of the blebs, thinning of the sclera, and this opens up the eyes much more to the risk of bleb-related infections. We want to avoid manipulation of surgery. For example, with trabeculectomies, if there are any releasable sutures, again, this always requires general anaesthesia in children. And we want to try and avoid putting foreign materials inside the eye because of the risk of erosion, because of the risk of infection, because of the risk of corneal decompensation. And we want to avoid the need for further surgery. You know, our mantra has always been the first chance is the best chance, and every subsequent operation that's done in a child, the success rate is lessened. Thinking about angle surgery in childhood glaucoma, we have the traditional goniotomy and the traditional trabeculotomy. These operations have really withstood the test of time, and you know, before these surgeries were described, the outcomes of children with glaucoma was dire. Traditional trabeculotomy opens up the drainage angle in less than 180 degrees of the angle, but it's really been with the circumferential or 360 degree trabeculotomy that the outcomes and the success rates, which I'll mention in a moment, have really improved. There is a cost factor with the 360 degree trabeculotomy, and there's been some very good research work published from Egypt, from Cairo, looking at two-site traditional trabeculotomy, again to try and increase the extent of the angle opening. And I think there's very good evidence that the greater the degree of angle opening that's done, the lower and more successful the outcomes of the angle surgery is. The circumferential trabeculotomy can be done with a Prolene suture, or more recently with an illuminated microcatheter, which I'll mention. And there's also been an ab interno approach with the Omni and also with the GATT procedure, which I really won't mention further during this talk. If we're talking about recent developments, it's always interesting to look back in history. And until several years ago, goniotomy was our first-line treatment in primary congenital glaucoma. And this was diagnosed, this was described by Otto Barkan in 1942, showing successful outcomes in 16 of 17 eyes, which was unheard of before this time. And my predecessor, but two at Moorfields, a doctor called Arthur Lister, travelled to San Francisco and learnt the procedure from Otto Barkan and brought this back to Moorfields, and he did the first goniotomy at Moorfields in 1947. And really this has been the standard procedure ever since, until the onset of the circumferential trabeculotomy. And you can see from the historical sketch on the left of the slide and the surgical video on the right that the procedure was very much unchanged for many decades. There are many indications for angle surgery. Obviously primary congenital glaucoma I mentioned, but there are many other types of secondary glaucomas where angle surgery has been used to successful outcomes, and we'll talk about those shortly. And I find in particular that uveitic glaucoma, juvenile onset glaucoma and steroid-induced glaucomas do tend to have a very good outcome from 360 degree trabeculotomy. We should never forget that goniotomies, as I mentioned, they've really withstood the test of time, and these are two children that had goniotomies in infancy and have been very well controlled without drops, with clear corneas and healthy optic nerves and good vision. And so it really was a revolution when goniotomies came into practice. And I think it's not until recently that there's been the second revolution in our surgical practice for congenital glaucoma. The history of trabeculotomy, the traditional trabeculotomy, dates back to the 1960s. This is another predecessor of mine, Redmond Smith. And in fact, he described this technique for opening Schlemm's canal, which again looks very similar to our current treatment of trabeculotomy. And he described using a suture. And this was back in the 1960s. And it was Hermann Burian, also in 1960, who developed the rigid trabecular tone to again open up the drainage angle, with overall fairly similar success rates to that of goniotomy. Now, I mentioned that circumferential or 360-degree trabeculotomy is not a new procedure. In fact, Allen Beck and Lynch, back in 1995, described the circumferential suture trabeculotomy with a blunted 6-0 proline suture. Having tried this procedure, I can see why it really didn't catch on in terms of its popularity, because you have to carry out simultaneous surgical gonioscopy because it's very difficult otherwise to know that the proline is in the correct position. Otherwise, there is a risk of the suture migrating posteriorly, and in some cases subretinally. And I think more recently, with the advent of the illuminated microcatheter, where the technique has taken off, because this allows continuous visualization of the tip of the catheter. And so again, if this starts to migrate posteriorly, then that can be dealt with. The advantage really is that the entire angle is treated in one session, and therefore this doesn't need to be repeated. So in the small percentage of patients where this is not effective, there's no need to repeat it. One then moves on to the next step, either trabeculectomy or glaucoma tube implant surgery. So the circumferential trabeculotomy involves using a light source and an illuminated microcatheter. And there's a red illumination at the tip of the microcatheter, and then that's passed 360 degrees through Schlemm's canal to complete the procedure. And I'll show a surgical video of this procedure being done. So the 360-degree trabeculotomy is generally performed in the inferotemporal quadrant. My preference is to do a conjunctival peritomy and then a triangular flap. We're not trying to form a bleb with this procedure. We really want just the flap to protect the underlying incision. And I also try and make the flap as thick as possible, because then that makes identification of the landmarks easier. Some surgeons will also carry out a deep flap, and again that's to identify the landmarks more easily, as is done with deep sclerectomy, for example, non-penetrating surgery. So the flap is extended into clear cornea, and so what we're looking for is the transition zone between the clear cornea and the sclera, and you can see that quite clearly in this surgical video. My preference is to carry out a radial incision over that transition zone and look for egress of aqueous. And then with a traditional trabecular tone, identify Schlemm's canal, which should just extend into Schlemm's canal without any force. Otherwise, there is a risk of having a false passage. When I know I've identified Schlemm's canal, then I will inject some Myocol and Provisc, a viscoelastic, into the anterior chamber to maintain the anterior chamber, and also to protect the lens from the eye tract microcatheter. So here you can see the eye tract being passed through Schlemm's canal, and I've always got one eye on the illumination, so I know that it's passing around the limbus and not extending posteriorly. And as you can see, I'm quite helpfully pointing out where the illumination is. In this case, you can see that the microcatheter passes with very little resistance, although sometimes you do get some resistance. Pulling the two ends then breaks the inner wall of Schlemm's canal through 360 degrees, and there you have an opening of the angle entirely. And when the incisions are sutured, you can see that the eye looks very much intact, with a blebless surgery and with no foreign material like a shunt in place long term. Post-operatively, I use a combination of antibiotic and steroid, Maxitrol for example, 4 times daily for 4 weeks. and also pilocarpine 2% twice daily, also for 4 weeks. And this is an attempt to stent the angle open while the healing process is going on. I stop all the glaucoma drops at the time of surgery. The main complications include high femur, and this is very typical to get a high femur, but it's very self-limiting, very rapidly resolving, and self-limiting hypotony as well. And this is why the viscoelastic is left inside the anterior chamber at the end of the procedure. In about 20% of cases, the Schlemm's canal is not continuous, and that requires a cut down to retrieve the end of the microcatheter from where the Schlemm's canal is blocked. And then you can carry out a partial opening of Schlemm's canal. And in many cases, a rigid trabeculotome can complete the 360 degrees. But there is quite a learning curve to the procedure, and this is one of its setbacks. Looking at some of the literature, these are fairly old papers now, but the first one looks at the 360-degree trabeculotomy compared with goniotomy in a case series of primary congenital glaucoma. This paper compared 24 eyes having trabeculotomy with 40 eyes having goniotomy. And you can see that the intraocular pressure was successfully controlled in 92% of the group having trabeculotomy, and only in 58% of the group having goniotomy, which is obviously a very clinically significant difference. In terms of visual acuity outcomes, in the trabeculotomy group, almost 80% achieved a visual acuity of 20/50 or better, significantly better than the goniotomy group with 53%. High myopia was much more prevalent in the goniotomy group, presumably because of uncontrolled and less effective control of pressure. And we know that with every diopter of myopia, there's an exponential increase in complications from myopia. So this is something that is useful to avoid. The follow-up, however, is slightly different, much longer follow-up, as you might expect in the goniotomy group than the trabeculotomy. The second paper compared goniotomy to the circumferential trabeculotomy with the illuminated microcatheter, and this looked at a retrospective case series of 24 cases. But again, the success rate, qualified success rate, was almost 92% compared with 54%. So fairly similar outcomes from the first paper I mentioned. This is a paper from my own group, and what we decided to do when we made the transition from conventional angle surgery, goniotomy, to microcatheter-assisted trabeculotomy, or 360-degree trabeculotomy, we wanted to compare our final 50 goniotomies with our first 50 trabeculotomies. So it would be expected that we were at our most experienced in goniotomies and our least experienced in trabeculotomies because of the learning curve. But despite this, the complete success at 1 year was almost 70% in the trabeculotomy group and only 23% in the goniotomy group. And looking at qualified success, this improved to 85% in the trabeculotomy group, but was still very poor in the goniotomy group at 37%. But as you can see, a much different clinically significant improvement with the newer procedure. This is also a meta-analysis published in 2020 looking at 5 eligible studies in a microcatheter-assisted group versus conventional trabeculotomy. And in all parameters, mean postoperative intraocular pressure, complete success rates, and lower use of anti-glaucoma medication postoperatively were all much more clinically significant and beneficial in the circumferential trabeculotomy groups. So overall, the traditional pathway of primary congenital glaucoma has been angle surgery and goniotomy if that had been possible, or traditional trabeculotomy if corneal clouding was present. Goniotomy and traditional trabeculotomy may well have needed to be repeated, and that may increase the overall success rate after the second procedure. And if that failed, which it did in many cases, then a tube implant or a trabeculectomy was the next part of the pathway. The congenital glaucoma pathway in 2022 is the 360-degree trabeculotomy on one occasion, and if that fails, then move on to the tube implant or trabeculectomy, whichever according to surgeon preference. So in conclusion, angle surgery is still the treatment of choice in primary congenital glaucoma. For many decades, traditional angle surgery, either goniotomy or traditional trabeculotomy, have had fairly similar success rates. But the 360 degrees or circumferential trabeculotomy has the ability to treat the entire angle with much more clinically significant improved outcomes. And the illuminated microcatheter assisted trabeculotomy may be safer because it allows continuous visualization of the tip and therefore prevents any inadvertent posterior migration of a proline suture. Many thanks for your attention, and
thank you, Dr. Brooks, for that great keynote. We have a lot of questions in line here. To begin with, I think there is one question which talks about whether pilocarpine would increase the extent of synechia formation post-operatively, and what do you think? Would you advocate the installation of pilocarpine drops after your surgery?
yes, I generally try and look at the angle post-operatively, and again, when children are brought back for repeat EUAs in children who've already had the trabeculotomy, I will do gonioscopy. And the angle's not completely open. There are some intermittent PAS often, but it doesn't seem to be enough to cause a problem in terms of pressure control. And we've done this procedure now really for about 6 or 7 years. And we're still getting outcomes at that length of follow-up of sort of 80 to 85%. And that's complete success. So the use of pilocarpine, I think, is beneficial, and I don't think there's a risk of causing progressive PAS.
Another question is, what percentage of your eyes in congenital glaucomas are you able to achieve a complete 360 degrees trabeculotomy, and whether a less amount of that would affect the outcomes?
Yeah, I think the extent of angle opening is very important in terms of outcomes. And when we've looked at some of the data, it's very clear that children having a complete 360 degree opening get better outcomes than if we've only managed to open 270 degrees. And again, better than 180 degrees. I can usually do a complete 360 degrees in about 80% of cases. Sometimes there is not a continuous Schlemm's canal, and the catheter stops at either 180 degrees or 270 degrees. And then we have to do a cut down. But again, we're still opening more than the angle that we generally achieve with goniotomy or traditional trabeculotomy. But I do think extent of angle opening does equate to better pressure control.
One question that I had is, does the extent of your ability to cannulate the entire 360 degrees depend upon the corneal diameters? In other words, do you think a child with a corneal diameter of, let's say, 11 or 12 millimeters would be more amenable to having a 360 degrees achieved in comparison to a child who comes with, let's say, 14 millimeters diameter or more than that? And
yeah,
in probably those severe cases, maybe a 360 degree cannulation is more difficult.
Yes, I think that's correct. I think in those cases where there's either been a delay in diagnosis or presentation, when you've got a larger corneal diameter, you've got more distorted angle anatomy. And so I do think it's true that it will be more difficult in those cases to cannulate 360 than if the children are picked up more, if they're picked up earlier and and less severe disease and less distortion of the limbal anatomy.
Yeah. Thanks a lot, Dr. Brooks. There are a lot of other questions, but we can take them as we go on with the next few talks, and we'll have Rahul, the next talk by Sirisha played, which is goniotomy. So Rahul, you need to play the pre-recorded talk now. Rahul, are you there? Can we have Sushmita, can you take over with your talk on the GAT?
Yeah, I'll do that, no problem. Rahul isn't around? Okay, I'll do that. So is it visible?
Yeah, it is. Yes, please.
Oh, okay. All right, I'll just go full screen and there you are. Okay, sorry. So thank you very much for everybody, and hello and welcome from me as well. And it's my privilege to talk about bent angle needle goniotomy or goniotomy assisted transluminal trabeculotomy as extensions of the goniotomy procedure that we know. So this is a quote that I like, and I think it holds true for pediatric glaucoma. Learn from yesterday, live for today, and hope for tomorrow. And the important thing is to not stop questioning. So the more we question, the more likely we are to come up with new things. So the basic concept we've seen, we bypass the non-functional trabecular meshwork and provide a conduit for aqueous to exit the eye. But could we do a little more than a goniotomy? So I'll just present the story of one baby and also illustrate the approach to the surgical management in PCG. So this 7-month-old baby girl presented with obvious ophthalmos, harp striae, and we took her up and we thought, but she also had a flat nasal bridge and redundant periumbilical skin. So we took her up for an EUA, planning a GAT, wondering whether it's axonfilled rigor. So under anesthesia, the left pressures were 26, and she had these quite big, large synechial sort of thing, a little more than the filiform that we saw, but not quite the axonfilled, but maybe the axonfilled anyway. So of course, there was a large iris insertion as well, a high insertion. The right eye angles were better, but we could still see the filiform processes and the dysgenesis there. But since the pressure was fine and the discs were normal and healthy, and this is through the central gonio lens, the left eye was obviously glaucomatous and cupped, so we decided to just do one eye surgery. So this is a short video of the GAT. So preoperatively, we use a Prolene suture. We don't have the illuminated microcatheter available in India, so it has to be rounded. And it is possible to do it with a little bit of corneal edema here, as long as the ankles are seen. We do inject pilocarpine before starting the procedure. And then a small goniotomy is made and the Schlems is exposed. And once we are sure, I also like to inject a little bit of viscoelastic at the incision, and I find that it just dilates it a little bit. I don't know why the video has stopped. Yes. So it just makes it probably a little easier for the Prolene to slip through. So this mouth is open. Now this is another incision through which we insert the 5-0 Prolene. And for this girl, it is at almost 12 o'clock or 11 o'clock in the left eye. So then this is a max grip micro forceps, which we use to just grip which is not too expensive and can be reused many, many times. So we use it to grip the blunt end of the Prolene and pass it through the trabecular meshwork. So pass it through the Schlems, I'm sorry. So you can see the harp striae is obscuring the view a little bit, but pretty soon the other end comes out, and you just hold it through with the max grip forceps and hold the other end using another plain forceps, and you just rip out the trabecular meshwork. For some reason the video is a little choppy, so here we are. So one end held and the other end, and it just pulls it out. So we've managed to do this in quite a few, and we manage a 360 degrees goniotomy at one go rather than just the other. So all was well for a while. You can see how the cornea is cleared. The other eye remained normal. Now this is something that we do in our clinics. We check the axial length while in the clinic. It has decreased the number of UAs that we need to do. So we've always seen that it reduces a little bit soon after surgery, the axial length, and then sort of goes on and then follows the normal curve. But interestingly, the right eye suddenly had an exponential rise, even though the pressures remained the same. So that's something we've seen, that even with pressures remaining all right, if we see an increase in the growth slope, that to us is an indication to be doing something. So in this eye, we thought maybe just a bent angle needle goniectomy would work. Maybe we could have done a GAT, but it looked so normal. I thought, let's just do that. And as luck would have it, this is one baby with both procedures, one in each eye. So the extension of goniotomy is really to remove a thin strip of trabecular meshwork rather than just slice it. So this is a bent 25 gauge needle, which I have on a viscoelastic syringe. So in case it's shallowing or there's a bit of hyphema, the resident or the assistant can inject it in. And you can see this is the bit of trabecular meshwork tissue that has come out. It's sort of a cheaper Cahoop dual blade, where the bit of trabecular tissue comes off, and you can see the back of the Schlemms, and the angle has opened up. So we did see this high iris insertion in our first EUA, and we thought we would do that. So meanwhile, we do clinical exome sequencing by NGS also. And she actually had a CPAMD8 variant, which is now a new gene for anterior segment distances and childhood glaucoma. So maybe those weird iris processes that we saw were characteristic of this. And now 4 months later, this is a recent picture. And you can see that the axial length is now coming back. So it had come down and then it's back, and now probably it is following the normal slope. So this was the slope initially, and this is what it is now, following the normal, we hope. And this is what she looked like on the EUA for the suture removal, which is important. So I asked Sandeep actually to look at our GAT results early, and we actually had 20 eyes of 17 children with a mean age between 6 to 11 months. So infantile PCG was the most amenable to it. And at 1 year, the 8 eyes that we did still maintained pressures of around 10 without medication, off drops, and maybe 1 or 2 in one of them, but they've done well, and none of them required anything. We did have one corneal infiltrate, which came because the child didn't come back for suture removal during COVID. We've had one choroidal detachment and one retinal detachment, but the transient hyphema has all resolved. So this is what this baby horrifically came with, and the fact that we could salvage this eye with a banana graft or something, and now we're struggling with the amblyopia. So these things happen. So I'd like to acknowledge the team. These are the residents who are working with me. Special thanks to everybody and to the consultants who make this all possible. And thank you very much. Hope to welcome you to India sometime. Thank you.
Thank you, Sushmita. Maybe we can have the next talk of Dr. Sirisha Plate. Rahul, and it's Dr. Sirisha's talk on goniotomy, please.
Good evening, friends. The topic for today is goniotomy. Way back in 1935, Otto Bakken performed the first goniotomy procedure in an adult patient, and that failed. With the learnings from that, he tried to do this procedure in a child and found good success, and then started performing this by using a special lens and a blade that he had designed, and published the first report of goniotomy in 1942. The primary indication for goniotomy was primary congenital glaucoma, and in certain types of secondary glaucomas with open angles. So the major problem in primary congenital glaucoma, as we know, is the abnormal trabecular meshwork development or trabecular dysgenesis, which is in fact called as isolated trabecular dysgenesis. So the children with primary congenital glaucoma present with various severities starting from clear cornea to total opacity. We know in PCG, surgery is the most definitive treatment. And of all the procedures that are available, goniotomy is the only procedure that is truly conjunctival sparing. The choice of surgery basically depends upon the clarity of the cornea, the horizontal corneal diameter, as well as the surgeon's experience. So clear visibility is very, very important for us to perform a goniotomy procedure. How do we visualize the angle? We use a direct gonio lens to visualize the angle. However, to perform a surgery, we require a surgical gonio lens that has a handle, so one would be able to visualize at the same time perform the procedure as well. In this picture, you can actually see the filiform processes moving from the iris to the area of the trabecular meshwork. That is the area that we need to concentrate on and try and increase the magnification to the maximum to be able to visualize this. Another important point I would like to share before I show you a couple of videos is for a good visibility, before we place the surgical gonio lens, a high viscous viscoelastic can be placed on the cornea that acts as a cushion between the lens and the cornea. That will prevent the folds on the cornea and the visibility will be much, much clearer. In those eyes where the corneal clarity is not very good, but at the same time, you would like to perform a goniotomy, it is also advisable to de-epithelize the cornea, and through the clearer stroma, one would be able to achieve this. The prerequisites, apart from having a surgical gonio lens, is that the microscope has to be adjusted in such a way that the microscope head piece is tilted towards the surgeon, about 35 to 40 degree, and the position of the head has to be in the opposite direction to the surgeon. It is definitely a quicker procedure. It is less traumatic and, of course, conjunctival sparing. Let us look at a couple of videos. This is a child with a glaucoma after a congenital cataract surgery with open angles. So you can actually see the technique. We're using viscoelastic on the cornea. An entry of the paracentesis is made with the help of a 24 gauge needle. We can either bend it or have a straight needle. And by visualizing through a gonio lens, the tip of the needle actually starts the incision just above the iris insertion, and you see that the iris tissue is falling back. I'll show you another video. This is a child with primary congenital glaucoma. So what actually it involves making a horizontal incision just above the iris insertion, and you will actually see that the iris tissue is falling backwards. And while doing so, you also will see a white band or a cleft that is visible. So you see this, you can engage the tissue just above the iris insertion, cut either clockwise or anti-clockwise. And you should have very, very minimal resistance because the tissue is so soft. If you're finding a lot of resistance, that means you are engaging or you're trying to pierce until the scleral edge. So with the help of an assistant who can rotate the globe, one would be able to achieve about 180 degree of goniotomy. So at the end of the procedure, sometimes, especially when you bring out the needle, one may see a little bit of bleeding. I don't think we should worry about it. We can either leave a small amount of air in the anterior chamber or refill the anterior chamber with the help of balance on solution. And always the paracentesis has to be sutured and suture it with a 10-0 nylon needle. One of the complications that occurs in these patients, any ab interno procedure that you do, especially when you're trying to open up the trabecular meshwork and Schlemm's canal, hyphema is a problem. So this can easily be cleared and the paracentesis are closed with the help of suture. Postoperatively, topical antibiotics and steroids, typically what we give after a procedure in a child. Topical pilocarpine is something that I prefer to use, and majority of us use for at least 4 weeks after the surgery. This prevents the pupillary dilatation and it prevents the iris adhesion to the cleft that is created. And especially because we are placing a suture, one may need to take the baby up for an anesthesia, examination under anesthesia, and remove that suture before it becomes loose and attracts infection. Certain modifications are also there, which people are using nowadays. With the help of a Cahook dual blade, they also perform a goniotomy. And a suture trabeculotomy is also something people are advocating, as well as doing it in children with congenital glaucoma, especially little older children or those with juvenile open-angle glaucoma. So especially with the JOAG, once you are able to identify the area of the trabecular meshwork, we should be able to do a ab interno 50-proline suture trabeculotomy, which is called the GAT. So we know that the results of goniotomy, especially from the West, when performed between the age of 1 month to 2 years in those with primary congenital glaucoma, success rates are very good, as high as 95%. However, those who are younger than 1 month of age, or with a very large corneal diameter greater than 13 millimeters of mercury, those with higher intraocular pressure at baseline have lesser success rate, and also so in certain patients with secondary glaucomas with ocular anomalies, the success rate seems to be lesser. Back in India, the goniotomy results have been published by Shushmita's group, where they evaluated children with primary congenital glaucoma as well as those with secondary glaucomas, or also included those with redo surgeries. And with a minimum follow-up of 6 months, they evaluated the success and outcomes of goniotomy. So they found that in PCGIs, close to 80% was the success rate. And if you look at that, with those with infantile glaucoma had better success compared to those with neonatal onset glaucoma. And the success rates with redo surgeries as well as non-PCGIs was definitely lesser compared to PCGIs. They also found 2 risk factors that predicted failure, which was the higher baseline intraocular pressure as well as the larger axial length. In a short pilot study that we had done some time ago, when we initially started doing goniotomy, so I started performing this as a second procedure in those with a failed primary combined trabeculotomy and trabeculectomy before doing a repeat trabeculectomy or an implant. So that's how it started. Or in those with secondary glaucomas with open angles like glaucoma in aphakia, pseudophakia, and spirophakia. So these were our results. What we found was complete success was not so great. However, with addition of 1 or 2 topical anti-glaucoma medications, at least 50% of these children did not require a second intervention. So that itself was a big boost for us. And after that, we started performing this as a routine procedure in those with primary congenital glaucoma with not much of a corneal edema or haze. Goniotomy is also advocated as a preventive measure in those with unaided glaucoma. In fact, David Walton's group has showed that those with prophylactic goniotomy in children who had not developed glaucoma, and when they followed them up for close to about 10 years, they found up to about 90% of these eyes did not have any rise in intraocular pressure. And in those who had a minimal rise in intraocular pressure, even they were controlled medically. On the other hand, in the cohort where the prophylactic goniotomy was not done, more than 50% of them developed glaucoma over an average follow-up of 8 years. So to summarize, goniotomy is a safe and an effective technique. It is definitely a boon, and it is a very quick procedure with less number of complications. It can be done as a primary procedure in primary congenital glaucoma or as a redo procedure, and definitely is helpful in those with secondary glaucomas with open angles. Modifications of goniotomy definitely can be considered, like the Kahoot-Duodate goniotomy, and especially in older children to perform ab interno trabeculotomy or the GAT procedure. And one should definitely understand the risk factors for failure and the benefits, and follow up these patients. And I think with this procedure, it is not difficult to learn, but the only difficulty we face is that once your needle goes in, you have to complete the surgery. So if, let's say, your resident or a fellow is performing this, you have very minimal time for you to take over and to complete the procedure. If that is the case, we can teach them in the wet lab. And the second thing that we can do is fill the anterior chamber with viscoelastic where there is better stability, and one would be able to perform this procedure, or train in our junior colleagues to perform this procedure. Thank you so much for your attention.
Thank you, Sirisha. We can go to the next talk by Dr. Sunita. We'll have the questions at the end. So Dr. Sunita's talk is on using the trabectome. Maybe Dr. Sunita can share her slides.
I had sent the video.
Okay, Rahul, so can we have Sunita Dubey? Okay. So in the meantime, Sunita gets gets with her talk ready, can we have one question from Dr. Sirisha? Any particular viscoelastic would you prefer, Dr. Sirisha?
Hi, friends. Viscoelastic, I prefer to use the Helon or Helon GV on the cornea. So intraocular for a goniotomy, I don't use any viscoelastic. In fact, we try and avoid shallowing of the anterior chamber to a great extent. So on the cornea, I prefer a high viscous viscoelastic. So a tip here is you place it on the cornea. You also place on the back side of the lens. So that gives a better stability and avoid having any air bubbles. So that significantly helps.
Right. Another question is, would you consider 24 gauge needle better, or would you use a 26 gauge needle when you're doing a goniotomy?
Yeah, so that's a very important question. This is something that we have worked on. So what happens is when you have large eyes with corneal diameter greater than 12, the 24 gauge needle, which is a half an inch needle, does not reach the opposite angle. So 24 is better, although the size is slightly larger, but I think it is fine because this is a 1.5 inch needle. It works well and it also has a better stability. So 24 gauge needle is what we prefer.
Yeah. Okay, thanks. Can we have Dr. Sunita? Dr. Sunita has a lot of experience using the trabectome, and she's going to talk about the use of trabectome.
So at the outset, I would like to thank IPGS for giving me this opportunity. My topic is goniectomy with trabectome in the management of developmental glaucoma. As we know, traditionally, angle surgery has been the first choice for surgical management of developmental glaucomas. And goniotomy has shown good success rate in mild to moderate PCGs, although it's not very successful in advanced PCGs. However, with the advancement of technology and advent of MIGS, we have now various other options to treat the angle. And trabectome is an electrosurgical gonioablative device which is used to perform excisional goniotomy and has the theoretical advantage of decreased risk of cicatricial closure of the trabecular cleft. Also, since it provides constant irrigation and aspiration, it is called irrigating goniectomy, which helps to maintain the anterior chamber and provides good stability of the anterior chamber and good visibility to facilitate ablation by removal of tissue debris and blood reflex constantly. Coming to the surgical steps, microscope and head of the patient should be adjusted to obtain the best view of the angle. It's important to look at the angle before starting the procedure. Give an incision of 1.7 millimeter at the temporal cornea. Enter with the irrigating trabectome. Start ablating on one side. Keep rotating the gonioscope and then start ablating on the other side and complete the ablation of around 120 to 140 degrees of angle, and then form the anterior chamber and apply sutures. I'll be showing you a few video clips. This is a patient of primary developmental glaucoma, and the trabectome was performed in both the eyes. And as you can see, the angle is visualized first with the Swan-Jacob type of lens. We enter with the irrigating trabectome and engage the trabecular meshwork and start ablating it. As you proceed, you see this white line, which is suggestive of outer wall of Schlemm's canal. So on the other side, and form the anterior chamber, and the other eye can be done in a similar manner. Another patient, after engaging the trabecular meshwork, started ablating the angle on one side along the arc of the Schlemm's canal. And as you can see, this child had this membrane which was obstructing the angle, the trabecular meshwork. So completion of the ablation on one side and then rotate the tip and start ablating on the other side. So there was a lot of blood reflux in this particular child, and which was removed by irrigation and aspiration, and then the eye was sutured. This third patient had the neonatal onset congenital glaucoma, and you can see the high insertion of iris, and we had failed trapezius trap, and you can see this white line suggestive of opening up of the Schlemm's canal, and you can see the posterior wall of the Schlemm's canal. So there is paucity of qualitative and quantitative data about the role of meds in childhood glaucoma. I'll be showing the results of 11 pediatric glaucoma eyes, which were classified according to CGRN classification, and we compared pre- and post-operative parameters of corneal clarity, intraocular pressure, anti-glaucoma medications, and complications. And the mean follow-up period was 6 months. The success was defined as achieving IOP of less than 18 with or without anti-glaucoma medications for complete success, resolution of corneal edema, and no further increase in corneal diameter, with no documented progression of the optic disc cupping. So out of 11 eyes, 7 eyes were primary congenital glaucoma, 2 eyes were glaucoma associated with non-acquired systemic syndromes, and 2 eyes were juvenile open-angle glaucoma. So trabectome was performed as primary procedure in 73% and as secondary procedure in 27%. And the average eggshell length was 23.69 and corneal diameter was 14.07. So the overall reduction in intraocular pressure was 39 for all the eyes. And there was some reduction of the medications also. The IOP reduction was quite remarkable in 7 eyes of primary congenital glaucoma, almost 46.4%, and 6 of the 7 eyes shows complete success at final follow-up. The corneal clarity improved and there was stabilization of corneal diameter and eggshell length. Results were not so good in juvenile, and both eyes failed in case of glaucoma associated with non-acquired systemic anomalies. And 1 eye which failed had very advanced glaucoma, the neonatal glaucoma with very high IOP, and the corneal diameter was 14.5 and eggshell length was 24.5. And literature also suggests the outcome of goniotomy and trabeculotomy is poor in advanced PCG. So the poor results in neonatal primary congenital glaucoma could be because of the very early developmental arrest and presence of trabeculo-iridocorneal dysgenesis and anomaly or abnormality of the Schlemm's canal as well. There's limited literature on surgical success of goniotomy in juvenile open-angle glaucoma, and the probable cause in these patients could be the extension of resistance to the aqueous flow to collector channels beyond trabecular meshwork. And similarly, in patients associated with anterior segment dysgenesis, goniotomy has limited success. So in our case also, there were progressive development of TAS. So to conclude, goniectomy with trabectome showed promising results in eyes with primary developmental glaucoma patients. However, large sample size and longer follow-up is required to ascertain the long-term safety and efficacy of this procedure. Thank you very much for your kind attention.
Thanks, Dr. Sunita. We will go on to our next talk by Dr. Gauri. If Dr. Gauri is ready with her slides.
Yeah, I am.
Yeah, okay. We can have you to share your screen, Gauri.
Just a second.
In the meantime, there's a question from Dr. Shanta regarding whether you can do a trabeculotomy. Dr. Sunita, can you do a trabeculotomy once you have had a failed trabectome surgery?
Actually, basically, trabectome, you're ablating the trabecular meshwork only. So You have already done it, but you have done it in the nasals, on the nasal side. So you have treated about 120 to 140 degrees on the nasal side. And if you want to do trabeculotomy from the superior side, you can do it, I think, because it is not 360 degrees. So you can do trabeculotomy in the remaining angle, especially superiorly. So you can do it. Yes.
Okay. Thank you. Thank you. Dr. Gauri.
Yeah, thank you. Thanks very much for the invite, and I'm enjoying this meeting. Can you hear me? Am I audible?
Yes. Yes.
Yeah, thank you. So cyclodestruction or cycloablation is a management modality for any type of glaucoma and also in congenital glaucoma. So we started off earlier with cyclocryotherapy, which was the first form of cycloablation, which was available, and later proceeded to diode transscleral cyclophotocoagulation and Nd:YAG laser transscleral cyclophotocoagulation. High intensity focused ultrasound circular cyclocoagulation also came up. And recently we have the micropulse TSCPC and also the endoscopic cyclophotocoagulation. So generally, the newer delivery methods, that is the micropulse and the ECP, offer relative safety and precision. But whatever the method employed for cyclodestruction, there are certain features in common to all of them. One, the destruction of the ciliary body is irreversible. So you cannot reverse the destruction. And if you end up with a low pressure, that is something that you will have forever. The dose response curve is also unpredictable. So you cannot say, I do one quadrant and I get X millimeters of mercury intraocular pressure reduction. That doesn't happen. Hypotonia and phthisis bulbi, therefore, are possibilities. There is always associated inflammation because it is a destructive procedure, and this brings with itself a lot of complications. And loss of visual acuity may result due to this inflammatory and other changes that happen due to cyclodestruction, and this can be a very important side effect. So when you look at histopathological studies following cycloablation, after TSCPC, you can see that the pigmented and the non-pigmented ciliary epithelium are separated, and there is coagulative necrosis of the underlying ciliary stroma, and there is gross destruction of the tissue architecture. However, after ECP, you can see that the non-pigmented epithelium and pigmented epithelium, there is clumping, and only those layers are destroyed without gross architectural destruction or collateral damage. So this might indicate that this is a more precise procedure. When do we consider cyclophotocoagulation? When we have high intraocular pressure and refractive glaucomas non-responsive to medical management, refractory meaning outflow enhancing procedures have been tried, but they are not successful or are not possible further. And if patients have useful vision, this is the criterion. If patients do not have useful vision and have a painful blind eye, this is usually the procedure of choice. So TSCPC, all of us are familiar with this, uses a diode 810 nanometer or Nd:YAG laser in the non-Q switched free running thermal mode. Diode is more widely used because of the better safety profile. These are the conventional settings for diode TSCPC, but of late there is a tendency to use low power for a longer period of time. This is supposed to give lesser side effects when compared to the conventional energy and duration. One should avoid the 3 and 9 o'clock position. The challenges in TSCPC in the pediatric age group, the eye with congenital glaucoma are very frequently large and the limbal anatomy is different. So the location of the ciliary body should be confirmed by transillumination. Also, sclera may be thin. One should avoid such areas of thin sclera and also areas with pigmentation. The destructive procedure may elicit more inflammatory response in children, and also the success rate in children is lower than with adults because younger eyes may recover from the treatment more rapidly. The ciliary epithelium regenerates more rapidly. Complications are varied, ranging from pupillary abnormalities, hyphema, inflammation, very importantly, hypotonia and phthisis. and almost 25 to 30% of eyes have a 2-line or more drop in the visual acuity. Rare complications include scleral perforation and sympathetic ophthalmia. So what does the literature say? The group by Penko et al., the intraocular pressure was less than 21 in 72% at 1 year and 51% at 2 years with multiple CPC treatments. So the success is good, almost 72% at the first year, but decreases over time. And single CPC treatments achieved success in 62% of children, and this decreased to 37% at 1 year. So you have a need for repeat procedures. Also, it was shown to have a similar efficacy and complication rates to sequential tube shunt surgery. Like you've done one tube shunt surgery, and instead of putting another tube, if you do CPC and compare that to putting a second tube, it is very comparable. Next, we go on to micropulse CPC. Here, there is an emission of laser energy in repetitive on and off periods. The off periods allow cooling off, and therefore they say this is less destructive. And here, rather than a point application, you have a slow, continuous painting motion along two arcs surrounding the limbus from 9:30 to 2:30 and 3:30 to 8:30. So it does not induce clinically evident tissue disruption and microexplosion. And according to the study published by L. Hefney et al., IOP was reduced significantly from 37.5 to 20 millimeters, and medications reduced to 2.6 to 1.7 with a micropulse TSCPC. Also, the complication rates appear to be lower when you compared micropulse to traditional transscleral cyclophotocoagulation. The publication by Abdel Rahman et al. Showed that there were 6 cases of complications like hypotonia in CPC, whereas only 1 case of hypotonia in the micropulse CPC in a group of 45 eyes. But there is a high treatment rate in micropulse compared to the continuous wave CPC, and also the IOP reduction may not be long lasting. That is, it is lost over time. Coming to endoscopic cyclophotocoagulation, here you have endoscopic visualization and laser delivery. The 810 nanometer diode is used, and you have 1/5 the energy that you use in TSCPC, and most importantly, you have a visible endpoint of shrinkage and whitening. So many times, this is the only procedure that one can do, like this patient of mine who had a huge staphyloma and scleral thinning, and here the other procedures were not possible at all. So here you can see that the endoscope allowed me to visualize the ciliary body in this cavernous anterior segment, and the precise endpoint of whitening and shrinkage of the ciliary processes can be seen. So this is the limbal route, and you can see that one after another, the ciliary processes are being ablated. So this is a very precise localization and laser delivery, so there is less collateral tissue damage. And this can also be done by the pars plana route. So compared to the limbal visualization, the pars plana, you can visualize the entire ciliary process and the interciliary, the valleys in between the ciliary processes. Most eyes require 360-degree ablation with indentation with the Q-tip. One need not be hesitant because it has been shown even in literature that 360-degree ablation is the one which provides a meaningful IOP reduction. So let us come to the efficacy. In the pediatric age group, Neely and Plager have done a lot of work on ECP. And one of their studies in 51 procedures in 29 children, there was a successful IOP reduction in 43% of the patients. But this success rate was a slightly higher one in pseudophakic and aphakic patients. And it's also said that ECP is useful after repeated failures of transscleral CPC. The success of ECP over time is also something which comes down because of the regeneration of the ciliary epithelium. In this study by Sharon Friedman's group, at the first year, it was 64%, which reduced to 36% at 3 and 16% at 5 years. And the cumulative success, where you had more than one procedures at 5 years, was 34%. So these are the kind of success rates that you can expect. But the rate of BCVA loss is less in the series with ECP uniformly. So in conclusion, cyclodestruction has evolved from a procedure that earlier used to be reserved for painful blind eyes. The limitation is that most data are from case series. What we know is that success wanes over time and there is a need for repeat procedures. But in a difficult subset like pediatric glaucoma, it definitely has a role. Thank you.
Thank you, Gauri. We will go on to the next talk, which is by Dr. George, and he's going to talk on low-cost glaucoma drainage implants in India for children.
Thank you. Thank you, Vinay. I hope I'm audible.
Yeah, you are.
Yeah. Good evening, everybody. So the Orolab aqueous drainage implant, or the RD, was developed to resemble the state-of-art 350 square millimeter barbell glaucoma implant. And the main purpose was not only to address the cost barrier of glaucoma drainage devices in resource-poor communities in the developing world, but it was also to address the non-availability of a proven non-valved implant in the developing world. So as far as safety and efficacy profiles of this cost-effective glaucoma drainage device is concerned, we have enough evidence in literature from PGI Chandigarh, LV Prasad Eye Institute Hyderabad, and Aravind Eye Hospital Madurai that the safety and efficacy profiles are comparable to any other implant which is being used worldwide in pediatric refractory glaucoma. So over the past decade, we have been thrilled to see this low-profile, thin-walled, larger surface area blebs forming over the barbell-like design, which is contoured to the shape of the globe. And to an enormous extent, we have been able to take out from the equation these tenon, cis, and bleb encapsulations, which were not very uncommon with the Ahmed glaucoma valve, especially in children and young adults. So again, over the past 5-6 years, we have also totally shifted to implanting the tube of glaucoma drainage devices in adults and in children through a 23 gauge needle generated 4.5 to 5 millimeters scleral track. And we see that the healing, the conjunctiva is minimally elevated, is as anatomical as possible in the original position, and also there's a smooth transition at the limbus. All this predisposes to excellent wound healing and less of inflammation. So this is a primary congenital glaucoma, a failed trabeculotomy, and the tube of the Orolab aqueous drainage implant is being threaded in through the scleral tract that was fashioned with a 23 gauge needle. So the important thing is to fashion a scleral tract which is of adequate length and depth so that the tube is well buried in the patient's own sclera. So over the years, we have had a lot of issues with tube exposures in the pediatric group with glaucoma drainage implants. And to a large extent, this technique has helped us surmount this problem of tube extrusions and exposures. We have been seeing tube retractions, tube corneal touch with this technique, but to a large extent, tube retractions have been taken out of the equation. So it's also important to oppose the tenons along with the conjunctiva at the limbus, and this is almost a year post-operatively. What we can see is good conjunctival healing, and we didn't find the necessity to remove the supramid suture. So this is a 15 millimeter cornea which underwent the RD implant. This is a congenital ectropion uvea, 5-year post-op of the same technique, and this child continues to do well, especially the conjunctiva at the limbus. We don't use donor patch material to cover the anterior edge of the anterior part of the tube anymore. Probably a decade back, we would have preferred infranasal quadrant as a preferred choice if for some reason we have to avoid the supratemporal, or for some reason we have to do a second tube. But we also looked at our results and found that the infranasal quadrant tubes in children don't do as well as the adult refractory glaucoma group. We found that the tubes fail due to inadequate intraocular pressure control and tube complications more in the infranasal group, and now we have totally shifted to the supranasal quadrant if at all we need to repeat a tube. And also the 3-0 supramid stenting that we have started doing in the Orolab aqueous drainage implant has definitely seems to have increased the safety profile of this implant. So this in a nutshell, this video in a nutshell will cover most of what I was telling about. This is an Axenfeld Rieger child. The first tube, unfortunately, has retracted. Still good conjunctival coverage, good healing. Tube is embedded in the patient's own sclera. This is the second tube, and the supramid suture gives us much more control over intraocular pressure post-operatively. Thank you very much, IPGS, especially Dr. Sushmita and Vinay, for this opportunity. And this legacy of Professor George Barwell will continue to live on with this cost-effective non-valve device, which has probably touched thousands of families in the most remote parts of developing countries and will probably continue to do so. Thank you very much.
Thank you, George. That was a wonderful talk and great videos. I think we are here for some questions to the panelists, Professor Arif, Professor Pandav, Dr. Rashmi, and Dr. Parivardhini are here with us. Dr. Rashmi, Dr. Parivardhini, if I would want to ask you, I mean, what would your choice be for a primary procedure if the child had come to you with a very large cornea or very large axial length? What would you do as a first procedure of choice?
Yeah, can I answer?
Yeah, please, Parivardhini, yeah.
Sir, in the large cornea, my choice would be a combined trabeculotomy, trabeculectomy. More than 14 millimeters, I don't prefer to do angle surgeries. I would do a trabeculotomy and trabeculectomy. If possible, trabeculotomy, definitely trabeculectomy, combined procedure.
Rashmi, your take on that?
Yeah, thank you, IPGS, for giving this opportunity. Yeah, like whatever may be the diameter, the primary surgery that we do will be combined trabeculotomy and trabeculectomy. But of late, we have tried GAT also in large eyes if the cornea is clear. So the primary procedure will be combined trabeculotomy and trabeculectomy.
Professor Arif, your take, if a child comes with a very large corneal diameter or a large axial length, what would your choice be as for the first procedure?
Thank you, Vinay, and thanks again for having me here, and thanks everyone. It's really nice to see everyone. You know, our experience here in the Gulf is a little bit different. We see a lot of bad primary congenital glaucoma, very not uncommon to see neonatal patients, neonatal glaucoma with huge diameters. And we have a much higher burden of CYP1B1 mutations than most other parts of the world. And something that I was very skeptical about in the past, but now I've become a convert for, is non-penetrating deep sclerectomy for these cases. And certainly in this region, Saudi Arabia, the Emirates, Kuwait, most of the glaucoma specialists who are dealing with bad primary congenital glaucoma are doing deep sclerectomy as an initial procedure. And I've been quite happy with the results. Now, of course, it doesn't always work, but it does get results in patients that we were often having failures with trabeculotomy and even combined trabeculotomy, trabeculectomy. So that's a whole other subject, but that would be the approach in this region.
That's interesting. I mean, if excising the trabecular meshwork with a trabeculectomy also doesn't give that good results, how do you think logically, without excising the meshwork, are you able to get such, results?
Yeah, well, yeah, that's a great question. And I don't think it has anything to do with excising the trabecular meshwork. When we do this, you know, there's a flap is made, a standard flap, and then another deeper flap is made just above the ciliary body level. And then you go all the way anteriorly into cornea, and you actually go into cornea a few millimeters. And this exposes Schlemm's canal, and it also exposes an area of Descemet's membrane over the cornea. And once you reach this area, you see this beautiful phenomenon of the fluid starting to ooze through. It doesn't rush through, it's not perforated, it oozes through. And then as the pressure goes down, it oozes less. And if you insert BSS, it oozes more. And I think this is my way of thinking about it. I don't have any, experimental evidence. And again, I was a big skeptic in the beginning also, but my way of thinking about it is when you leave this little thin tissue there, as opposed to a frank trabeculectomy, which is a hole, I think it's less immunogenic. I think that it tends less to seal off. That's my explanation. I'm not saying that's what's happening. But we do have real world experience here, and there have been some papers published about it. I know that it's not what most of the world is doing, but definitely in the Gulf, this is what people are doing.
Yeah, thanks. Because in India, I don't think many of us are doing a deep sclerectomy in children. I don't think, Dr. Pandav, what would you do in such a child who's come to you very severe? Any experience of yours with deep sclerectomy in kids?
No, I think that's very interesting because we never actually considered a deep sclerectomy for such cases, but I think RF is doing it, and maybe next time one can look at it as well. But our approach is basically, and my approach would be that I'm sort of more inclined towards trabeculotomies rather than combined surgeries. So whenever possible, if the Schlemm's canal can be identified, I would like to do a trabeculotomy, rather than a goniotomy. If possible, that would be done, but I think such eyes are usually not suitable for these procedures. And if any of these procedures is not possible for some reason, then probably I'll go with the trabeculectomy and they will use some mitomycin C and see if that works. Of course, the chances of failure would be higher, but that's what I would do in a situation like that. If you don't have an option of doing goniotomy or trabeculotomy.
Yeah. Okay. Thanks. Thanks. That was great. We will go on to our next keynote lecture, which is by Professor Franz Gren. And I would like to share the screen, Rahul, and maybe you can prepare Professor Franz talk. So Professor Franz is from Germany. He's a professor of ophthalmology at the University Hospital of Würzburg in Germany. And Professor Franz has been the president of the World Glaucoma Association. He's also been the president of the Glaucoma Research Society. He's been the president of the German Society of Ophthalmology. He's a great surgeon. He has a lot of experience in dealing with pediatric or childhood glaucomas. And I have had the opportunity to discuss Axenfeld Rieger's, into which he has great interest in. And apart from numerous publications and great surgical experience, he has a lot of knowledge to share. So with that, we will go on to the lecture by Professor Franz on what to do in follow-up of children with childhood glaucoma and how best to get good functional outcomes. So Dr. Franz Grenz, please.
First of all, I want to thank the organizers for this honorable invitation to your distinguished symposium. I'm very glad to talk to you today. During the decades of my career, I was always involved in treating congenital glaucoma, and therefore follow-up strategy and functional results after childhood glaucoma surgery are something very important. I have listed some bullet points here, but we will not cover everything. However, IOP measurement is important because the methods have changed during the last years. Axial length growth has great importance for follow-up. as has fundus photography if we cannot use OCT. Visual acuity and all functional results such as refraction, strabismus, and stereopsis are of utmost importance for the little child that has to develop good vision. And therefore we need intervals and a clear scaffold for follow-up examinations. This is to show to you that there are lots of differences in prognosis and follow-up needs for different types of congenital glaucoma. On the left-hand side, you see the 360-degree trabeculotomy in primary congenital glaucoma, and in this small study, all eyes resulted in pressures below 18 millimeters of mercury, most of them without any further medication. Whereas if the situation was a secondary congenital glaucoma, many cases needed therapy, and some of them also were above a threshold of 18 millimeters of mercury. So for follow-up, it is important to distinguish between primary and secondary congenital glaucoma, to consider the age of manifestation, etc., etc. Now, congenital glaucoma damage, be it at the cornea or at the optic nerve, is a pressure disease. So pressure measurements are very important also post-operatively, especially in those cases where we cannot be sure that the operation has solved the problem. Up to now, applanation tonometry by handheld instruments was used and is certainly a very precise method. However, it is not applicable to children of young age in the awake state, and therefore it was a great achievement when rebound tonometry became available. And nowadays we can use rebound tonometry in the awake child and also in the very young babies during sleep and independent of the body position. However, I want just to mention that we need old things like our fingers to have an estimate of the intraocular pressure after operation, and I would argue that one should, as a young resident and later, calibrate the fingers in adults when we know the intraocular pressure, to use them afterwards in children when we cannot do any examination, for example, immediately after surgery on the next day. And therefore we can have an estimate whether the pressure is very low or very high, or whether it's in the normal range. There are pitfalls of IOP measurements under general anesthesia, as we all know. And this is an example that has a lot of details that are relevant for follow-up. This child was operated at the age of 1 month on his right eye because of primary congenital glaucoma with metal probe trabeculotomy. And 9 months later, at the age of 10 months, there was an examination under anesthesia with the following results. The corneal diameter increased a little bit. It was a large cornea from 13.5 to 14.5 or 12 to 13 millimeters, but there were no decimal tears. But the axial length growth in 9 months increased by 4 millimeters in the right eye and by 3.5 millimeters in the left eye. So there was a clear sign of increased axial length growth in this child. The optic disc showed glaucomatous excavation. So despite there were no decimal tears, the diagnosis was, of course, congenital glaucoma with intraocular pressure, but the intraocular pressure did not increase very much, obviously, because under anesthesia, the right eye showed an intraocular pressure of 12 millimeters of mercury, in the left eye of 14 millimeters of mercury, and there were some contradictions between refraction, optic disc, axial length, and so on, and intraocular pressure under anesthesia. And finally, we tried to measure by ballistic tonometry in the sleeping child, and it turned out that the pressure was grossly elevated. So there was a huge difference between the intraocular pressure during anesthesia versus intraocular pressure during sleep or in the awake child. Therefore, the escape strategy can be that we measure intraocular pressure during general anesthesia immediately after initiation of anesthesia, but nevertheless, these things can occur, and I would strongly recommend to use the ballistic tonometry in the awake child whenever possible, although it needs some patience and the child must cooperate. But during sleep, it is possible in many cases. We are unfortunately not able to use ketamine anymore. Ketamine was injected intramuscularly and for examination of children, but it is not allowed in the Anglo-American and also in European countries anymore. Decimal tears are a clear sign of congenital glaucoma if present, but if they are not present, we cannot assume that there is no congenital glaucoma. So during follow-up time, it is very important to always look for decimal tears, and this can best be done in coaxial light with the red reflex from the fundus in a dilated pupil, as you see on the left, whereas it can be overlooked at the slit lamp or at the general illumination of the operating microscope, as you see in the middle or the right-hand picture. Corneal diameter is usually used to document progression or stability of a congenital glaucoma, but I must say I'm not rely very much on this type of measurements, although we can do it with calipers or with rulers or with a centimeter band, as you see on your upper left. However, it does not represent really the arc length. It's not a surrogate of the arc length of the vaulted cornea, because the more the cornea is vaulted, the less you will measure increments of diameter in an enlarged eye. And in addition, the limbus can be very stretched, and from one observer to the next observer there might be differences where the limbus is set. So it was not surprising that in our study the corneal diameter was not changing very much. On the left you see the bilateral cases, on the right you see the unilateral cases. Both have a very flat curve, and therefore the information is limited that we can draw from corneal diameter measurements. However, if it comes to axial length measurements by ultrasound, the measurements can be more precise and can give you a much better estimate whether the intraocular pressure is controlled or whether it's still growing. You see on the left hand all eyes. The red line summarizes the 68 eyes that we observed over a longer period, and the blue line underneath shows the normal growth of the eye under healthy conditions in young children. On the right-hand side, you see unilateral cases, and the blue line are the healthy eyes that really match very good with the normal values of the normal curve. This is a more complicated graph, but it basically shows you that if the intraocular pressure after operation is still elevated, the eye will also grow further and faster than the normal curve. On the abscissa, you see the final IOP after surgery from 0 to 46 millimeters of mercury, with a vertical blue line at 21 millimeters of mercury. And on the ordinate, the y-axis, you see the slope of growth as compared to normal. So if the slope of growth of an individual eye was equal to the normal curve over the respective period, then the quotient of both values is 1. If the growth was faster, then the value is above 1. It might be twice as fast or 3 times as fast as the normal curve. If the growth is slower than the normal curve, which also occurs after operation, then the growth of the eye is slowed down and goes similar to the normal curve or goes close to the normal curve. So in the upper right quadrant, you see that with high intraocular pressures over 21, most of the eyes have doubling or 3 times as fast growth of the axial length. Whereas if the pressure is more or less controlled, here below 21 or below 15, then these values are all below 1 or not much over 1. So in these cases, the growth of the axial length of the globe has been halted by the operation. As it comes to optic nerve head, of course, documentation is difficult because we cannot use OCT in the small children, but therefore I really recommend to have a handheld fundus camera. In the lower pictures, you see the right and left eye of a baby of 1 month of age, and this is a unilateral case in the right eye. Here you can see that the disc is enlarged, probably due to myopia and photographic changes of perspective, but you also see that there is an excavation in the center. And to follow up these cases, fundus photography should be available from the first examination and the follow-up examination as well. Gonioscopy is not very important, but should be done once in a while in the case of general anesthesia, because then you can check whether there are synechia following the operation, whether the canal is really open in circumferential trabeculotomy, as you see on the right-hand side, or whether there are other changes such as cyclodialysis or whatever can occur. So in the right-hand slide, you see the white line, which is the back of Schlem's canal, the bare sclera. In the left photograph, you see the double arrow, where the entrance into the anterior chamber was avoided by maintaining the descimate membrane and to avoid any prolapse of the iris, whereas at the neighboring part of Schlem's canal, the canal is open, as you can see from the other arrows, where you see the white line of the bare sclera of Schlem's canal. When it comes to function, we all need patience with these little patients. This girl, for example, was complaining about the wrong sweater that she was wearing, and we needed about 7 minutes to have her smiling and then taking the visual acuity. In our study, visual acuity, here taken as logMAR values, does not increase over 0.4 decimal values on average in congenital glaucoma. This is probably not only due to amblyopia, it is also due to refraction, irregularities of the cornea, stray light by desmatiers, etc. So in our recent study, as well in the old studies, from the 20th century, late 20th century, we have found that most papers report a vision of visual acuity of 0.4. And of course, it's more difficult in unilateral cases because amblyopia is more prevalent in these cases. As it comes to refraction, these eyes, of course, are myopic, and you see that myopia doesn't change very much on average in our follow-up cases. However, when you look to unilateral cases, you see that myopia even increases in later stages, although these numbers are, of course, small. But amblyopia by itself may be a factor that drives myopia in these cases. Therefore, amblyopic treatment and myopic correction are equally important. If you correlate myopia to axial length, usually we have 3 diopters per millimeter of axial length in the adult myopia of non-glaucoma cases, but in glaucoma this correlation is a little bit different. So as you can see from this graph, 2 diopters per millimeter length came out from the regression analysis of these cases, and it was also surprising that there were hyperopic cases in green and quite a lot of emmetropic cases. So the correlation between axial length and refraction is clear, but it is not clear how much it would be in the individual case. Strabismus is a problem because usually the orbit of a young child is small and the globe can be very large in ophthalmos. So it is not surprising that exotropia prevails. About 3/4 of cases that we could check for strabismus, or who had strabismus out of 43 cases, had exotropia, and only 1/4 had esotropia. As it comes to stereopsis, we could find that in bilateral cases, there is a surprisingly high proportion of children that have some stereopsis tested by the lung test, whereas, of course, in unilateral cases, amblyopia hinders to develop stereopsis much more than in bilateral cases. One short remark to genetic testing, because that is not only something for diagnosis, but if not done at the primary presentation of the child, one should not forget to talk to the parents for genetic testing, because the difference between phenotyping and genotyping can be very large. And I just show you this old picture where in one side you have the corneal opacity, which is similar to Peters anomaly, whereas in the other eye that was Axenfeld-Rieger's syndrome. So both things can be manifest in the same child as both eyes are monozygotic twins. And I just summarize some of the flaws that I recently had between phenotyping and genotyping. One is the PTX2 for Axenfeld-Rieger and Peters anomaly, but also we had a mother with Peters anomaly that delivered a child with aniridia. And one of the examples that I really remember very much was that girl on your right-hand side, the photograph, where all over her life, she's now 40 years of age, was was taken as a Peters anomaly, and she didn't want any genetic testing until a few years ago, when she wanted to be a mother, become a mother, and therefore wanted to have a risk analysis. And it turned out that this bilateral corneal opacity was not Peters, but was CYP1B1. So the risk of delivering a congenital glaucoma child with a father who is not affected should be very, very low. So to come to an end, follow-up strategies need to analyze the risk level for each individual case, whether it's secondary glaucoma, a very young manifestation, or a corneal opacity, etc., etc. But it also needs a scaffold, what we do at what point of follow-up, be it the surgical team or be it the orthotic specialist who is the next to follow the child. And the examination type, of course, shifts very much away from general anesthesia, as long as intraocular pressure is the main parameter that we want to follow, because that we can do in the awake child with some patients with the eye care tonometer. And the examination intervals are, of course, very individualized, but for the parents, I usually suggest that after the first day check-up, we see them in 1 week, 3 months, 6 months, 9 months, and 12 months. And some of these appointments should be for the surgical team to control the morphologic state, and the others, or even at the same time, the child can be seen by orthoptic specialists. So in summary, some points: rebound tonometry allows to reduce examination under anesthesia. Axial length measurement is much more reliable than checking corneal diameter for follow-up. And morphologic follow-up and functional follow-up must interdigitate. And finally, genetic testing should not be omitted if the parents have disagreed at the start of the disease, but should be offered later as well to define the risk of transmission of this disease. Thank you very much for your attention.
Thank you. Thank you, Professor Franz. That was great lecture. I think there's so many points that we need to think about when we are looking at your slides. One question that comes to my mind immediately is the last thing that you said was the intraocular pressure, the fundus, and the axial length. All of them need to be taken into account when you are following up a child. But which of these three parameters do you think is more important? Let's say if the axial length is not increasing or the optic disc is not changing, yet the intraocular pressure is high. So would you consider such children to undergo some intervention, or would you wait for the axial length or the optic disc to show changes?
This is, of course, a special situation. Usually the parameters match, and you have high pressure and axial length growth and excavation paralleling over time. But in your case, when there is no change in the optic disc and no change in the axial length, I would wait for some months and check the pressure. As we have this ballistic tonometry now, I think it's more easy, and children will learn just simply as a play to comply with this technology. And I'm very, very enthusiastic about that approach. So I would follow, even within some weeks, if the parents do not travel too far. In Germany, it's possible that they come back 2 weeks later or so.
Yeah, thank you.
I would not indicate further surgery because, as you know, I favor 360-degree trabeculotomy, and the next step would be something of filtration surgery, and this is more invasive. And before I do that, I would really know whether you need it.
Dr. Mandal, any comments from you regarding your follow-up? When would you consider to take up a child for a resurgery?
Yes, the question is when axial length is stabilized, even if the pressure is little on the higher side, when you are checking intraocular pressure under anesthesia, depending on the optic disc and other parameters taken into consideration, probably I'll be in favor of supplementing with medical therapy and plan for repeat examination under anesthesia. Because intraocular pressure checkup under anesthesia, so many things can.
Yes. Dr. Sushmita, Dr. Sushmita?
Yeah.
What would your take be if you have a child who's just showing a high pressure and yet the rest of the parameters are normal?
So as Dr. Gren said, it would be really unusual. I would really wonder. And one place where this happens I've seen is in aphakic glaucoma, where the corneas are thick and rigid. So that could be one cause of pressures being high, but everything else. But if the axial length is following the curve and the disc is normal, I would just wonder whether my pressure measurement is at fault rather than a progressive glaucoma, and just wait and watch. And I would intervene if I saw change. I wouldn't intervene if everything else was stable. Refraction, vision, axial length, those are all my surrogate measures now. And as time has gone on, intraocular pressure has really gone lower on my progression parameter.
Dr. Pandav, how would you react to a child who's showing a high IO intraocular pressure?
I think we had some wonderful lectures, and thank you for including me into the program. I think in this situation, my only comment is that the axial length is a good, good indicator of whether it's, it's stabilizing or not. But I think that has to be interpreted in view of the age of the child also, because axial length would tend to stabilize with age as well. So I think this is only good for, say 1 year or 2 years, up to 2 years. But beyond that, I think that you lose that, advantage of measuring axial length. And around that time, probably you have to come back to IOP and other parameters, particularly the IOP and the optic disc appearance, basically, to guide you more over, corneal diameter or axial length.
Thank you so much. I think we'll go on to our next session of free papers. We are well within time, and I would request the moderator, Dr. Purvi, to take over along with Dr. Praful. Dr. Ramakrishna is chairing the session, and all of these free papers are pre-recorded. So we will have the judges evaluate them, and so this is the second session, Dr. Purvi.
Yeah, thank you, Dr. Vinay. And it has been a super session actually to begin this virtual meet. And welcome all to this second session on paper presentation, as Dr. Vinay just said. So we have 6 papers in all, and as just mentioned, they are all pre-recorded presentations, but each presentation it will be followed by a 2-minute live discussion. So I would request the presenters to be on stage and turn on their videos when their video is over, and there would be a small discussion of 2 minutes or any questions put forth by the judges. The papers would be scored on the basis of the scientific content, the overall presentation, and of course the clinical utility of the content. Before we begin, I would quickly introduce the judges for this presentation. We have Professor John Brooks. He has just given a wonderful keynote lecture. He's from the Moorfields Eye Hospital and is also a board member of the UK Pediatric Glaucoma Society. We have the second judge, Professor Franz Grain, again, who just gave a beautiful keynote lecture on the follow-up strategies for the patients. He's from Germany. Professor Arif O. Khan, who is a consultant pediatric ophthalmology and ocular genetics from Abu Dhabi, UAE, and is also associated with the Cleveland Clinic of USA. And we have our own Dr. Gauri Murthy from Bangalore. So I would request now the IT team to please play the first presentation. It is by Dr. Karthikeyan Mahalingam. It's on U-Tool, a novel method for measuring corneal diameter in infants screened for congenital glaucoma. Mr. Rahul? Yeah.
U-Tool, a novel method for measuring corneal diameter in infants screened for congenital glaucoma. As is known, corneal enlargement is a common feature of congenital glaucoma. It is an important indicator for both diagnosis and monitoring the progression of the disease. Castroviejo caliper is being routinely used for measuring the corneal diameter, but it needs examination under anesthesia or sedation. We devised a simple U-shaped tool using 3 shimmer strips or a printable ruler to measure corneal diameter in settings where an ophthalmic caliper is not available or UA is not feasible. Infants presenting to the congenital glaucoma clinic posted for EUA were recruited. Before EUA, corneal diameters were measured using U-Tool. During EUA, corneal diameters were measured using Castroviejo caliper. Corneal diameters obtained from both the techniques were compared. For measurement in a cooperative child, U-Tool was placed just above the orbital rim. If not cooperative, when the child was asleep, the eyelids were gently retracted by the attendant and U-Tool was placed. Photo was taken with the smartphone. Care must be taken to keep the U-Tool and the smartphone parallel to each other so that parallax error doesn't occur. After taking photo, the image was edited in the image editing software. A rectangular frame was drawn along the limbus extending till the U-Tool and the first reading was calculated. This image shows corneal diameter measured in various children in awake or sleeping state. As we do not place the U-Tool directly on the corneal limbus to measure the corneal diameter, a correction factor must be applied for the magnification caused due to the distance. The distance from the corneal limbus to U-Tool was measured using a ruler in all the eyes and was approximately 16 mm. The correction factor at 16 mm distance was deduced to be approximately 1.15 mm. The corneal diameter was calculated by multiplying the first reading with the correction factor. The mean age of the participants was 6.7 months. 66% of the eyes had primary congenital glaucoma, 22% of the eyes had anterior segment dysgenesis, 8% of the eyes had post-cataract surgery glaucoma, and 4% of the eyes were normal. Figure A shows that the corneal diameters measured using the Castroviejo caliper and U-Tool were almost similar. Figure B shows that if we don't apply the correction factor, the uncorrected U-tool reading was approximately 1.5 mm lesser compared to that of Castrovich caliper reading. The difference between the corneal diameters measured using the Castrovich caliper and U-tool was 0.11 mm with a narrow bland Altman plot 95% limit of agreements. Corneal diameter measured with both instruments had a good correlation with a Pearson correlation coefficient of 0.95. Measurement error could occur if the U-tool or a phone is not placed parallel to the eye while taking photographs. Sedatives or anesthesia might be required in a non-cooperative child. Stretched limbus in congenital glaucoma could also cause variation in measurement of corneal diameter by different observers. To conclude, this novel innovation provides a no-touch technique of measuring corneal diameter. Considering a difference of 0.5 mm within the acceptable range, 72% of the readings taken with the U-tool were in the acceptable range. It provides corneal diameter measurement in awake or sleeping state without the use of sedatives or anesthesia in majority of the cases. Hence, it can be used for screening pediatric glaucoma by first contact physicians, optometrists, or even by the ophthalmologist when the UA is delayed. Thank you.
Thank you, Dr. Karthikeyan. Any questions or comments from the judges?
Dr. Purvi, that was a nice presentation, Dr. Karthikeyan. If you factored the distance from the eye of the U-tool, but if the child's face is rotated or if the eye is not straight, then how do you account for the accuracy of the measurements?
Ma'am, we have to retake the photo again, ma'am. If the child face is tilted or eyeball is not straight, you have to retake the measurement again, ma'am.
Any other comments or questions?
Yeah, can you hear me?
Yes, please, Professor Arif.
Yeah, thank you for that nice presentation. I think it might be challenging to get that ruler placed properly for children at a standard distance. Maybe a next step could be somehow incorporating that into the software rather than having to hold that object by the child's face. Have you thought about that at all and while you were doing this?
Yes, sir, we were thinking, sir, we will try to do it next time. The distance, if the distance is standard, we can make in the ruler itself, we can calibrate according to distance, sir. Instead of applying a correction factor, we can make it, sir.
But just an important point, it has to be at this a certain distance from the eye, and that's the challenging part.
Yeah, we tried to mount it on a spectacle, that U-ruler, and keep it, and we tried, sir, but it is under process, sir.
Thank you.
Okay.
We have 10 seconds left for this. So any other questions or comments? Professor Gren, you just mentioned about the corneal diameter in your presentation. So any comments from your end?
Professor is muted.
Oh, I'm here again. Sorry about that.
Juvenile high pressure open-angle glaucoma diagnosed.
Mr. Rahul, yeah, sorry. Yes, Professor Gren.
Yeah, the problem is probably the geometric optics. So we used to stick a centimeter band on the front of the child and then took a tele lens, because then a tele lens from greater distance that the mobile phone would allow. And therefore, the difference between the projection of the centimeter band and the diameter of the cornea might be less important. So that was our solution. But I really would prefer your approach, because you have the photograph and you can overcome the problem of defining the limbus, because if in repetitive measurements in the OR or wherever you do it, different people will measure different values because the limbus is so undefined in large corneas. And therefore, the photograph that gives you the picture where you can measure according, one person can measure at different time points. That is a great advantage, I think. On the other hand, as I mentioned, the geometry of the diameter is something different from the vault of the cornea, because what we really want to measure is arc length. And what we do measure is a planary distance that is a surrogate, and it becomes more and more, let's say, flawed if the cornea is very extended, because then the slope of the corneal vault does not allow to measure increments very well.
Thank you so much. Yeah. We now move on to the second paper, that is by Dr. Bindu Somarajan from RPC AIMS. The presentation is on juvenile glaucomas and multilocus disease causing genome variations. Mr. Rahul, please.
Today we will be talking about juvenile glaucomas and multilocus disease-causing genomic variations. To begin with, juvenile high-pressure open-angle glaucoma diagnosed before 40 years of age have shown to be genetically heterogeneous. And with the advent of next-generation sequencing technology and family-based sequencing, more and more loci are being revealed that are associated with JOAG. Whole exome sequencing carried out in trio family design has more diagnostic rate than proband-only whole exome sequencing. Besides this, multilocus disease-causing genetic variants as well as multiple genetic diagnosis is revealed with the help of next-generation sequencing. And the presence of these MGV has far-reaching consequences on the phenotype. Some of these are listed here. That is, the individuals with MGVs may present as blended phenotype or with distinct phenotype. Individuals with MGVs may have age-dependent penetrance, sometimes one phenotype obscured by another phenotype, sometimes two distinct phenotypes in different individuals in families with same MGV. In this study, we carried out whole exome sequencing in 40 trios where the proband was affected with JOAG. In 8 of these, one of the parent had glaucoma while the rest were apparently sporadic. For the experimental protocol, genomic DNA was isolated from peripheral blood sample of the proband and family members, and whole exome sequencing was performed on Illumina HiSeq platform. And we looked for pathogenic variants in the known glaucoma genes or those genes associated with any other ocular disorder. And the basic workflow of whole exome sequencing involves various steps. That is, after the wet lab protocol, we obtain FASTQ files, and a quality evaluation is done using several bioinformatic pipelines, and subsequently alignment with human reference genome 19 or AG38. Further variant calling and annotation is done. And for variant interpretation, several filtering strategies are adopted on parameters like genotype quality, read depth, allele frequency in the general population, functional consequences of the variants. And lastly, we followed a combination of criteria for variant interpretation according to the guidelines of American College of Medical Genetics and Genomics, AMP guidelines, for interpreting whether the variant is pathogenic, likely pathogenic, or benign, or of uncertain significance. Coming to the results, in 4 out of the 40 families, we found MGV based on the known genes for glaucoma. And molecular diagnosis for more than one pathogenic variant was established in 25% of the autosomal dominant families and in 2 sporadic GOG. 8 individuals from these families, these 4 families, had different multilocus genomic variations. Here we describe the findings of 4 of these families. In the family with an autosomal dominant GOG, both myelin and LTBP2 mutations were seen in 4 members. In another autosomal dominant family, we found a rare EFEMP1 variant along with a COL11A1 mutation. And the proband then established to have Stickler syndrome. In the 3rd family, myelin and LTBP2 pathogenic variations were found. And in the 4th family, along with LTBP2, we found a TEC mutation contributing to GOG, and the results which we obtained here is interesting because we found LTBP2 mutations to be associated with GOG, which is classically seen with subluxated lenses. However, there is a prior report before ours where an association with GOG is established for LTBP2 gene, and the association with TEC mutation and GOG is also reported for the first time. This is a recent report from our group where we established a digenic inheritance pattern in GOG family with myelin and LTBP2 mutations. In the first family, the proband was a young girl presenting at 10 years of age with severe bilateral GOG. Her father was also blind with glaucoma, and on screening the family here, 2 younger siblings were diagnosed with ocular hypertension, and all the affected individuals carried both myelin and LTBP2 variants. The proband had a normal anterior segment with open angle and advanced glaucoma. In the second autosomal dominant family, the father had ocular hypertension while the proband presented with GOG at the age of 24 years. And we found a COL11A1 mutation that is known to be associated with Stickler syndrome. The proband was a high myope. And on careful examination, her vitreous showed a beaded appearance. She had a myopic disc. She also gave a history of hearing impairment, which was attributed to trauma at a young age. There are only 2 cases of EFEMP1 mutation noted among GOG. The gene has been recently discovered and associated with adult onset POAG. The variant we found here is a rare one and has not been reported with glaucoma so far. This is the model of mutant arginine 148 EFEMP1 protein. We observed that arginine 148 forms hydrogen bond with proline and glycine at 158 position, and helps to maintain the conformation of the loop where it lies. And since EFEMP1 is known to have a role in cell addition and migration, the loop carrying arginine 148 might have an important role in interaction with the cognate protein. Hence, the change in loop conformation would lead to a decrease in its binding to cognate proteins, and the substitution in 148 position from arginine to cysteine may not be able to hold the loop in its naive conformation because of its inability to form hydrogen bonds with the adjacent residues and having a shorter side chain compared to arginine. So this substitution may compromise the function of the protein to some extent. In the third family, the proband was born of a consanguineous marriage where neither of the parents were affected, and she was the only one affected with JOG with an age of onset at 11 years. She also had a diagenic glaucoma associated with myelin and LTPP2 variation. She also presented at a young age with advanced glaucoma. And in the fourth family, had a sporadic occurrence of GOG where the proband presented at 40 years of age, and none of her parents were alive for genetic testing. She was found to harbor mutation in both TEC and LTPP2 gene. She also presented at a young age with advanced glaucoma. So to conclude, 3 of our 4 patients had an LTBP2 mutation presented with a severe JOG. Whether LTBP2 is associated with a severe form of angle dysgenesis that can result in severe GOG, that needs to be established with further studies. An association of TEC with LTBP2 is described for the first time, and we were able to diagnose Stickler syndrome in a JOG patient who had NEF-FMP1 variant with the help of whole exome sequencing results. And NGS helps in better diagnosis and may help in prognosis, and could be used more often if the technology gets cheaper. So lastly and most importantly, the study highlights the impact of systematic phenotyping through analysis and recognition of MGV in the genomic data. Thank you.
Questions from the judges?
Yes, can I ask a question?
Yeah. Yes, please.
That was a very good presentation, thank you. Do you think this information and knowing the genotype in other family members in patients who present with advanced disease might influence your management of lesser affected or pre-diagnosis patients in the same family? Is it going to change your management?
Yes, of course, this NGS data and gives an opportunity to do more screening and monitoring, and to give if for treatable conditions, this would be helpful.
Make some
Professor
comments?
Arif? Yeah. Yes.
Yeah.
Yeah.
First of all, congratulations on taking on this topic. It is very challenging to try to tackle, and I congratulate you for having the courage to do that. This is really a huge topic and very interesting points that you bring up. I don't think in this scope of this presentation and the time we have, we can really see whether or not those are truly pathogenic variants or not. It's very difficult to demonstrate that variants are pathogenic, even if they come in a quote unquote glaucoma gene. Rare variants in genes are common. So any of us are carrying rare variants in genes, and teasing out whether or not they're contributing to a patient's phenotype is a very tricky situation. And I congratulate you for tackling it. I'll just ask just a few questions. One, the diagenic cases that you were mentioning, were they variants on the same allele, or were they on different alleles?
They were on allele in different allele in the sense it was there was only one variant in each gene. So
so you had the you mentioned, I think, myocilin with LTBP2,
yes,
correct?
Yes, myocilin with LTBP2. Both the variants were present in heterozygous conditions.
Right. So the MYOC variant could be enough if it is a pathogenic variant to explain the phenotype, and
yes.
it could be that the LTBP2 variant is not contributing.
Yes, the proline 370 leucine variant we obtained in that digenic family. The report says that the penetrance of the disease with this particular mutation is around 75% by the age of 25 years. But in our cases, the penetrance was for both the carriers, the penetrance was at the age of 15 years. So we assume that this LTBP2 enhanced the pathogenicity of myocilin proline 370 leucine. So
it's a very interesting to dissect this out, and I'm sure you've looked at it very carefully. We don't have time to really discuss that. I'll just say one more thing that was interesting. You mentioned the EFEMP1 variant. That's also, there's one particular variant in that gene that's associated with dominant drusen. I wonder if that patient had drusen or any macular findings.
Clinical findings, I'm not that sure.
Yeah, because there's a variant in that gene. I think it's been associated with juvenile open-angle glaucoma in a Filipino family.
Yes, Filipino family, and around 2% in Chinese POAG patients.
Yeah, but also it's known to cause dominant drusen, but a specific mutation. So it'd be interesting to get a look at that patient's macula carefully.
Okay.
But thank you again. Really a very sticky situation, sticky topic to tackle, and I think you did it well. But I think it needs a lot of discussion and investigation whether or not to prove the variants that are found are pathogenic or not. I'm not doubting that, but it just requires a high level of proof.
Yeah, functional studies are required for the variants we obtained, at least with EFEMP1, because that is the variant we are reporting it the first time to be associated with glaucoma. So that needs to be established on a functional basis. But we did a bioinformatics study. So, but yeah, wet lab experiments are also required to establish that.
Thank you very much. Thank you.
Thank you, Professor Arif and Dr. Bindu. These are in fact all discussions which warrant independent sessions in themselves. So we move on to the third paper by Dr. Shikha Gupta, again from RPC AIMS. The presentation is on risk factors for nitarsudil-induced honeycombing in pediatric glaucomas.
Namaste to all of you. Today, I, Dr. Shikha Gupta, am presenting on the risk factors for nitarsudil-induced honeycombing in pediatric glaucomas. So we all know that the nitarsudil, which is a Rho kinase inhibitor, is a new IOP-lowering drug in the market. It is a potent Rho kinase inhibitor with additional norepinephrine transporter inhibitory action. It is supposed to be a potent IOP-lowering drug. Additionally, it also helps in clearing corneal edema in normotensive eyes by endothelial cell regeneration, proliferation, and wound healing, and is routinely used for clearing corneal edema in eyes such as Fuchs endothelial dystrophy by the corneal people. There is limited literature supporting the use of nitarsudil in pediatric glaucoma. In this only study that we could find, only 50% of the patients, pediatric patients in whom the nitarsudil was administered, they could achieve a 15% IOP reduction, and 2 or 3 patients also showed an increase in IOP with no severe side effects seen except for the conjunctival hyperemia, which was almost present in 50% of the cohort. So therefore, the study was conducted to look at the IOP lowering effect of nitarsudil in pediatric glaucomas. So the children with uncontrolled IOP on maximum topical medications were given a trial of nitarsudil, If IOP remained uncontrolled on topical medications, the child was then taken up for surgical intervention. Basic clinical data like age, baseline IOP, post-nitarsodal IOP was recorded. During follow-up, some eyes were seen to develop corneal epithelial honeycombing, as a result of which comparison of clinical characteristics was then made between groups who developed corneal honeycombing and B without corneal honeycombing. So this is the preliminary results that we could obtain. We can see these depictive pictures of corneal honeycombing in congenital glaucoma, along with the ASOCT picture showing edema concentrated at the level of epithelium only. So 16 eyes in pediatric glaucomas were administered nitarsodil, of which group A, 9 of 16 eyes developed honeycombing, of which IOP could not be controlled in all of these eyes, whereas 7 eyes did not develop honeycombing, of which IOP remained controlled in 6 eyes, and in 1 eye, IOP could not be controlled. Looking at the comparative data, the mean age of the two groups was significantly different. The group which developed honeycombing was much younger than the group which did not develop honeycombing, with a difference of almost like 6 years. The mean baseline IOP was high in both the groups, and post-nitarsodal IOP, though there was a significant decrease in both the groups, but there was a significant difference in the two groups also, with the IOP being higher in eyes which developed honeycombing. Mostly eyes who developed honeycombing had some kind of underlying dysgenesis. Like most eyes, they had primary congenital glaucoma. 2 eyes had Axenfeld-Rieger syndrome. 1 eye had post-traumatic glaucoma, and 1 eye was juvenile open-angle glaucoma. On the contrary, eyes which did not develop honeycombing, they most likely had secondary glaucoma. The diagnosis included operated VR surgery, steroid-induced glaucoma, uveitic glaucoma, and post-traumatic glaucoma. So 7 of 9 eyes in the group with honeycombing, they had pre-existing corneal edema, whereas no eyes in group B had some kind of pre-existing corneal edema. Angle dysgenesis was present in the 6 eyes in whom ASOCT could be performed in group A, whereas in 6 eyes in which the ASOCT could be performed, only 1 eye showed the collapse of Schlemm's canal. So these are various pictorial presentations of the honeycombing that we see, and these are congenital glaucomas. These are different. There are 3 different patients, and we can see how reticular kind of edema they present with. On ASOCT interoperatively, you could see dysgenesis present, high iris insertion with the membrane over the angle, and the edema being concentrated in the topmost epithelial layer, giving it appearance of reticular kind of a edema. This is another patient, 9-year-old girl with juvenile open-angle glaucoma, who also developed honeycombing, and we also see that there is angle dysgenesis with absence of the Schlemm's canal formation in this child. 1 eye with post-traumatic glaucoma also developed honeycombing, as it is seen. It was more located in the inferior part of the cornea. So the potential uses of nitarsodil, they include rapid endothelial recovery, and partly the aim in this study was maybe nitarsodil might help in clearing the corneal edema and rapid endothelial recovery following the Harp striae formation in this cohort. Also, we proposed or presumed that corneal clearing in eyes with high IOP having corneal edema would also occur. However, this paper shows contradictory results that nitarsodil can actually exaggerate corneal edema in eyes, especially with angle dysgenesis and high IOP. There is a possibility that stromal fluid is pushed into the epithelium due to permeability of the tight junctions, and then there is absence of aqueous drainage through the angle, as we have seen that there is collapse of the Schlemm's canal. So this fluid, which has been pushed from the stroma into the epithelium, is now not being able to drain through the angle and is getting concentrated within the epithelial layer because of the underlying angle dysgenesis. Therefore, we learn that nitarsodil can exaggerate corneal epithelial honeycombing. The risk factors for the same, they include any eyes with pre-existing corneal edema and high IOP, eyes with angle dysgenesis and collapsed Schlemm's canal, like we saw in our eyes with primary diagnosis like primary congenital glaucoma, Axenfeld-Rieger syndrome, or juvenile open-angle glaucoma. Younger age, again, at a higher risk for development of corneal epithelial honeycombing. Hence, when we are prescribing nitazoxanide in pediatric glaucomas, we should be aware that there are certain relative contraindications in pediatric subjects where we should refrain from using nitazoxanide, especially those indications where a surgical intervention would be definitively needed, like these eyes with primary diagnosis of congenital glaucoma or Axenfeld-Rieger syndrome. Thank you very much for your patient listening.
Thank you, Dr. Shikha. Yes, the rho kinase inhibitors actually came as being friendly to the corneal endothelium. So, any questions or comments from the judges?
Yeah, thank you for that very clear presentation. You might have mentioned it and maybe I missed it. Did you stop the medicine, and what happened if the medicine was stopped to those who developed the honeycombing?
Yes, sir, that is a very relevant question. So most of these cases required surgical intervention for IOP control because it was not being controlled. So the medicine had to be stopped, and the honeycombing reverses itself within 3 to 4 days as soon as the IOP is controlled surgically, and it doesn't sustain.
Thank you.
That was a very nice presentation, Dr. Shikha.
Thank you, ma'am.
Did I miss something? What was the duration of the treatment? Did you correlate the duration of the treatment with the occurrence of honeycombing?
So typically we have dates running for the admission of congenital glaucomas. So it is almost like 1 to 2 weeks before we can admit them. So we start the nitazoxanide at the time we see the patient. So it was typically 1 to 2 weeks before we could admit and do the surgery. And in most of the congenital glaucomas, we could see that honeycombing has been precipitated by nitazoxanide during this time. Within 1 to 2 weeks, ma'am. Within this time.
1 to 2 weeks.
Yes.
Okay. And there was no difference in the time duration of topical treatment between the two groups? The one who developed and one who didn't develop?
No, there was no difference.
Okay.
Thank you. So with that, we move on to the fourth presentation by Dr. Venkatesh. The topic is comparative evaluation of corneal features in PCG and Axenfeld-Rieger syndrome. Mr. Rahul?
Hello everyone. Today myself, Dr. Venkatesh Nathia, will be presenting before you all a presentation on comparative evaluation of corneal features in primary congenital glaucoma and Axenfeld-Rieger syndrome. At the outset, I would like to thank all members of the IPGS and the esteemed faculty members and the judges and panelists for providing us this opportunity. I'm also grateful to all my co-authors, Dr. Karthikeyan Mahalingam, Professor Seema Sen, Professor Jeevan Singh Titiyal, Professor Vinay Gupta, and Shikha Gupta ma'am. Talking about a little background of our study, angle dysgenesis of primary congenital glaucoma, that is PCG, and Axenfeld-Rieger syndrome, that is ARS, has been explored in the past where they have studied the aestheticity of the angle. They have described presence of an abnormal membrane at the angle, presence of high rising pars with the area of hypolucency in between them, and posterior corneal morphology has also been studied in eyes of primary congenital glaucoma, that is PCG, using ASOCT, and histopathology showing thickening of Descemet's membrane and predescemet's layer with peripheral extension up to the angle recess. In this study, we describe and compare corneal characteristics in PCG and ARS. For ease and simplicity, I will be using the acronyms PCG and ARS in place of primary congenital glaucoma and Axenfeld-Rieger syndrome. In our study, 26 eyes of PCG and 40 eyes of ARS were included. The following parameters were noted: clinico-demographic profile of the patients, which includes intraocular pressures at baseline, corneal diameters, ASOCT study, ocular biomechanical parameters using Corris ST, and corneal aberration profile on eye trace. Histopathology and immunohistochemical staining with the help of collagen 4 was done in these patients wherever keratoplasty was performed, and data was analyzed with IBM SPSS Statistics 23 software with appropriate statistical tests. Looking on to the results, we see that sex ratio was pretty much comparable between the two groups, but we see that cases of primary congenital glaucoma presented much earlier as compared to the cases of Axenfeld-Rieger syndrome. Also, the baseline IOP was comparable between the two groups, but the average corneal diameter was significantly higher in cases of PCG than ARS. Also, the baseline cup disc ratio was comparable between the two groups, but out of every 3 eyes, 2 eyes showed presence of half striae or breaks in the Decimet's membrane in cases of PCG, whereas such was only 5% cases in cases of ARS. And the corneas were also relatively thicker in cases of ARS. These are clinical pictures of a case of PCG showing half striae or breaks in the Decimet's membrane, and this is a rare case of an Axenfeld-Rieger syndrome showing breaks in the Decimet's membrane, which can be ascertained with the help of ASOCT as well. On ASOCT, a posterior corneal hyperreflectivity was present in 100% PCG eyes vis-a-vis 85% eyes of ARS. The presence of a double membrane sign on the posterior cornea indicated a thickened pre-Decimet's layer and Decimet's membrane was visible exclusively in eyes of PCG. Angle dysgenesis was comparable between eyes of PCG and ARS, with ARS having a little higher frequency. On wavefront aberrometry, the refraction was comparable between the two groups, and the most common total ocular aberration was astigmatism. On studying the corneal biomechanical profile, the first apprenation velocity was 0.03 meter per second higher in corneas of PCG than ARS, indicating an increased deformability to stretch in eyes of PCG than ARS. So we come to a question: why is there an increased corneal diameter, greater frequency of half striae, and increased corneal deformability in eyes of PCG as compared to ARS, despite greater angle dysgenesis in eyes of Axenfeld-Rieger syndrome? On histopathological analysis, we came to know that the Decimet's membrane thickness in eyes of PCG and ARS was comparable, and the pre-Decimet's layer thickness in eyes of PCG was greater than eyes of ARS. On immunohistochemistry, all tissues of PCG and almost 90% tissues of ARS were collagen 4 positive. On collagen 4 immunohistochemical staining of pre-Decimet's layer, most of the tissues of PCG had shown a positive staining, whereas majority of ARS tissues were collagen 4 negative. Hence, on histopathology and immunostaining, the results indicated a prominent, thickened, and collagen 4 positive pre-Decimet's layer in corneas of primary congenital glaucoma, and an inconspicuous, thinner, and mostly non-collagen 4 staining pre-Decimet's layer in corneas of ARS. So, there is a significant difference in the collagen composition of pre-Decimet's layer in corneas of PCG and ARS, and an absence of collagen 4 in pre-Decimet's layer of Axenfeld-Rieger syndrome. Corneas suggest an altered microstructure and an anomalous PDL in cases of Axenfeld-Rieger syndrome. To conclude, the corneas of ARS are smaller in corneal diameter, thicker, less deformable, and have less frequent half striae compared to primary congenital glaucoma. And the difference in characteristics of pre-Decimet's layer may cause difference in corneal stretchability and subsequent enlargement between the two groups, as has been noted in our study. We believe an anomalous PDL could play a role in preventing corneal stretching in cases of Axenfeld-Rieger syndrome, and development of half striae is also affected in these eyes, making ARS corneas less deformable than PCG corneas. With these remarks, I would like to conclude my talk and thank you all for your patient listening and attention. Thanks a lot.
Any questions or comments from the judges?
So once again, another great presentation. Thank you again for that nice presentation and that hypothesis you put forward. But there's an alternate hypothesis that I'd like to suggest. You know, the patients, the patients who have very early onset glaucoma are the ones with the congenital infantile glaucoma, and the ones who have a later onset glaucoma are the ones who are the Axenfeld-Rieger cohort. Could it be the age of onset of the glaucoma, as opposed to whether it's Axenfeld-Rieger versus quote-unquote infantile glaucoma, be the determining factor for these histological findings, rather than the histological findings being the cause for the differences that you're seeing? Because we see variable expressivity. Many patients with CYP1B1 mutations have a very severe neonatal glaucoma, but some of them have juvenile glaucoma, some of them even have adult onset glaucoma. It's coming on at a different age. And Axenfeld-Rieger syndrome, as you said, is usually juvenile, but there are some patients who are congenital glaucoma. So could it be the time of onset of glaucoma versus whether we're labeling it as primary versus Axenfeld-Rieger? Could that be the determining factor in your findings?
Yes, sir. I would like to say that that is definitely a difference between the two groups. But at the same time, despite having comparable corneal diameters and axial length, still the patients of Axenfeld-Rieger syndrome usually tend to present a little late because of this feature of the cornea. Once the cornea is stretched and there's a blepharospasm, the patients notice, especially in a socio-demographically poor country like India, the patients tend to come late, the attendants tend to come late. But once the patient does not develop grossly abnormal features because of an anomalous PDL, which we believe, which is preventing the stretch in these cases, the patients, where already age is a factor in Axenfeld-Rieger syndrome, the patients tend to develop also present a little late to our clinics because of that.
So you're suggesting that the Axenfeld-Rieger patients actually had glaucoma very, very early on, but they didn't have corneal enlargement because of these findings in the histology?
They do tend to develop the glaucomas late, sir, but they may present early. We can catch these cases early if there are some grossly abnormalities which can be observed by the parents. But if the corneas are relatively normal in diameters, these tend to present late to us, and this may also delay the treatment given to these patients.
Thank you. Thanks for a very nice presentation.
We move on to the second last presentation by Dr. Sandeep Chaudhary from PGI Chandigarh. The topic of presentation is newborn glaucoma, a neglected manifestation of congenital rubella syndrome. Mr. Rahul, please. Yeah, thank you.
Hello, everyone. I'll be discussing newborn glaucoma, a neglected manifestation of congenital rubella syndrome. I have no conflict of interest to declare. Our study was conducted at a tertiary care center in northern India, which caters to about 9.83% population of the country. Intrauterine infections, especially rubella, can affect various structures of the developing fetal eye. It may present with glaucoma and cataract in the newborn. Etiology of glaucoma in these cases is known to be trabeculodysgenesis or persistent viral damage to trabecular meshwork. The purpose of our study was to report the incidence of rubella positivity and early treatment outcomes in a cohort of babies with newborn glaucoma. Institutional Ethics Committee clearance was acquired for our study, and infants with glaucoma aged less than 4 weeks and those who presented between October 2017 and December 2018 and had completed at least 12 months follow-up after the surgery were included in the study. Rubella IgM titers were done for all the study participants, and rubella positive and rubella negative groups were compared. The presenting features, including intraocular pressure, corneal clarity, corneal diameter, lens status, axial length, and the surgical outcomes, were compared between both the groups. A total of 27 patients met the eligibility criteria. Out of them, 7 patients tested positive for rubella and 20 tested negative for rubella. So 13 eyes of 7 patients were compared with 34 eyes of 20 patients. At presentation, age at onset, age at presentation, and intraocular pressure had no significant difference between both the groups, while rubella positive babies had significantly worse corneal clarity, smaller axial length, smaller corneal diameter, and a coexistent cataract which was noted only in rubella positive group. Systemic associations were also noted in rubella positive babies. Heart disease was seen in 3 out of 7 patients, while hearing deficit was seen in 1 out of 7 patients. At 6 months follow-up and 1 year follow-up, there was no statistically significant difference in intraocular pressure between both the groups, while the corneal clarity remained poorer in rubella positive group at 6 months and 1 year follow-up. So the cornea cleared significantly in rubella negative group but not in rubella positive infants despite comparable intraocular pressure reduction. Improvement in corneal clarity was better in rubella negative babies as compared to rubella positive babies. As we can see in these photographs, the patients on left are from rubella positive group while on the right are from rubella negative group. So at 1 year follow-up, we can notice that improvement in corneal clarity is better in rubella negative group. Rubella positive group patients also required additional procedures for visual rehabilitation and cosmesis. These included 7 out of 13 eyes, which required lens aspiration, optical iridectomy, evisceration and prosthesis in 1 unsightly blind eye due to anterior staphyloma, which we can see in this photograph. Rubella negative group, 6 out of 34 eyes required additional procedures, which included optical penetrating keratoplasty and optical iridectomy. Newborn glaucoma in rubella positive cases are phenotypically different. They have smaller eyes and a persistent corneal opacity which is not related to raised intraocular pressure alone. Cases of unrecognized congenital rubella infection might be mistakenly diagnosed as intractable congenital glaucoma. So any glaucoma with a smaller eye should raise suspicion of glaucoma with rubella. Now coming to how big is the problem. So incidence of rubella is known to be 65.57 per 1 lakh live births to 225.58 per 1 lakh live births according to constant and age dependent force of infection models. This translates into 14,520 and 50,028 infants with congenital rubella syndrome every year, which constitutes a large part of the global congenital rubella syndrome burden. Structural heart defect, 1 or more eye signs including cataract, glaucoma, pigmentary retinopathy, and hearing impairments are commonly encountered in these babies. 10 to 30% of adolescent females and 12 to 30% of women in reproductive age group are susceptible to rubella infection in India. Commonly thought of ocular features of congenital rubella syndrome are cataract and salt and pepper retinopathy. Glaucoma is less commonly recognized. It is very important to suspect rubella for prognostication of disease, explanation to the parents regarding infective nature rather than the hereditary nature of the disease, and screening for systemic associations like cardiac disease and hearing impairment. Also, the parental counseling regarding the need of vaccination is important. Thank you.
Thank you, Dr. Sandeep. Any comments or questions from the judges?
Yes, thank you very much for that very clear presentation. In the UK, we see very few children with rubella syndrome because of our vaccination program. But when I do see a child with glaucoma with neonatal onset and associated with a cataract, then rubella's one of the things that I always think about. I may have missed this, but in the group of rubella negative children, did any of those have coexistent glaucoma and cataract?
No, sir. There was no case with coexistent cataract in rubella negative group. So
and do you have is there a vaccination program in India?
Yes, sir. Yes, sir. Measles rubella vaccination program is currently ongoing in India, which is specifically targeting the adolescent age group.
Is there a regional difference between the incidence of that infection or consequences, or how is the vaccination in southern, central, and northern India? Is there differences that would explain the high incidence in your cohort?
So regional differences I'm not aware of, but if you see the global picture, then Southeast Asia and specifically India amounts to a large part of the global congenital rubella syndrome burden.
I have two quick questions.
Sorry, Dr. Khan, you can go.
No, go ahead.
No, as for just to answer Dr. Gren's question, I think in Bangalore there was this trial initially of the vaccine, and so there was some evidence that in the south of India, at least in some centers, the incidence of rubella is a little lesser when compared to northern India. So there may be a regional variation. Just to answer Dr. Gren.
Thank you.
Yes, Professor Khan, you had
just two very quick questions. I mean, thank you. I mean, you're educating me about this. I don't have much experience with rubella glaucoma. I have two quick questions. One, have you ever seen a unilateral case that was attributed to rubella? Does that exist or no?
Yes, in our cohort also we have seen
unilateral.
Unilateral, yes.
And the other is, any of these patients, not necessary, but just out of curiosity, any chance of testing them for CYP1B1 mutations? That's something
no,
that might be
we haven't done this testing in our cohort, but yes, this is something we can take up for future.
Very, very interesting presentation. Thank you.
Thank you, sir.
Thank you. With that, we move on to the last presentation of the session by Dr. Raquel Quintanilla. It is on ocular hypertension among children with typical fundus coloboma, a single center series from Bascom Palmer Institute, Miami. Mr. Rahul.
Good day, everyone. My name is Raquel Quintanilla. I am a research fellow at Balkan Center at Baskin Palmer Eye Institute, and I am grateful for the opportunity to present this abstract today. Here are my co-authors. I have no financial disclosures. Visual acuity in fundus coloboma can be affected due to the extension of the chororetinal involvement and/or the association of ocular comorbidities such as microphthalmos, microcornea, cataracts, and the occurrence of retinal detachment and amblyopia. Ocular hypertension and glaucoma have been rarely described in association with coloboma. However, large fundus coloboma that enclose the optic disc can be very challenging for the diagnosis of glaucoma. In general, the classification of fundus colobomas revolve around the optic disc involvement, as well as if the disc itself is colobomatous or not. Here we can see some images of fundus colobomas spectrum, from those that appear peripheral and respect the optic disc, all the way to severe forms that make it very difficult to identify the disc. The aim of this study is to report outcomes of the treatment of ocular hypertension and glaucoma among patients with fundus coloboma and determine possible factors associated to IOP control in these eyes. We performed a retrospective chart view of patients diagnosed with coloboma who developed ocular hypertension from 2010 to 2021, treated at our institution. The data collected includes age at the time of diagnosis of ocular hypertension or glaucoma, ocular characteristics, glaucoma treatment, and pre- and post-IOP. Ocular characteristics and the association with IOP control were evaluated using Fisher exact test. Coming to results, we found 24 eyes from 20 patients with fundus colobomas and ocular hypertension or glaucoma. Age at the time of diagnosis was 11.9 years old. Coloboma affected in most cases both the anterior and posterior segments. 62% of these colobomas involve the optic disc and the macula in some degree. Microphthalmos and microcornea were found in approximately half of these eyes, and retinal detachment occurring 29% of these eyes. Concurrent presentation of ocular hypertension and coloboma was most commonly unilateral. 58% of eyes were diagnosed as glaucoma suspect based on a persistently high IOP in eyes where the disc could not be properly evaluated due to large colobomas. 42% of eyes had glaucoma diagnosis, most of them subsequently to PPL, PPV due to retinal detachment. The mean IOP at the time of the diagnosis of ocular hypertension was 29 ± 9. This pressure was higher in eyes with microcornea, microphthalmos, cataracts, and coloboma involving optic discs compared to eyes that did not have these abnormalities. However, the difference of IOP was not significant for any of these variables. These eyes were followed up for a median time of 3.4 years. 6 eyes remained under observation only, 13 received anti-glaucoma medications, and 5 underwent 1 or more glaucoma procedures. This graphic shows the pre- and post-IOP among the 18 eyes that received treatment. We defined final IOP as the mean of IOPs obtained in the last year of follow-up or at least 3 consecutive visits. We went from a mean pre-IOP of 30.7 to a final IOP of 21.8. IOP reduction of at least 20% was observed in 72% of eyes treated, whereas IOP of 21 or less was attained in 67% of eyes. We found no difference in IOP control between surgical and medical treatment. Inside the circles, there are 5 cases that underwent glaucoma procedure. 3 of them developed glaucoma after PPL and PPV. Case 7 and case 9 had no prior surgeries. In case 7 and 12, the primary surgery was a GAT, which failed to control IOP, but it was finally achieved after 2 consecutive GDD plus a CPC in case 12. None of these variables here show association with final IOP control. Nevertheless, eyes with glaucoma secondary to ocular surgery appears to achieve better pressure control than those without prior surgery, showing a marginal significance. This may be related to the fact that most of these eyes receive more aggressive management through GDD implants. We concluded that fundus coloboma with abnormal disc pose a challenge in the diagnosis and progression assessment of glaucoma. Most patients appear to control well with either medical or surgical treatment. However, treatment might be especially challenging in a subset of patients who present with anterior sigmoid dysgenesis with a very shallow anterior chamber and anomalous Schlemm's canal. Here are my references. Thank you all for listening, and I will be pleased to answer any questions.
Thank you, Dr. Raquel. Any questions from the judges?
So I have 2 questions. Nice summary, nice, interesting cases. I might have missed this. I think you mentioned it. How many of these were patients who had fundus colobomas and did not have prior surgery?
So only 7 patients did not have surgery, like prior ocular surgery. Basically, these 7 patients have PPL and PPV. Most of them because of retinal detachment, and one of them because of cataract extraction luxectomy and a PPV and a PFV.
Yeah, so these patients who didn't have prior surgery, I mean, in my experience, it's very rare to see glaucoma in patients with coloboma. It's, I mean, it's not impossible, but it's not something that happens often. So one thing I would think about is, I don't know, did anyone look at corneal thickness? Because sometimes these eyes are deformed a little bit, and maybe the cornea is a bit abnormal, and that's causing the high IOP. Was that considered at all?
Yeah,
the high measured IOP.
Yeah, indeed, the corneas were measured in all patients, and there is corneal thickness in these patients, and we were actually trying to, it's a very small series, and the intentions, first of all, was just to do a description of the series, given the fact that this is a very, very rare concurrent anomaly. It's been described by Tribawal actually in a Bodia group in India. They found 0.3% to 0.6% of patients that have concurrent coloboma and glaucoma. So we were very curious. Actually, this was brought by the senior actor, Dr. Elena Pichian, who I'm very grateful to. And the issue with these patients is that indeed we try to we tried to assess if there was like any influence of microphthalmos or macrocornea. We did not find anything, obviously, because it's a very small series, but yeah, it's an issue that we indeed would like to consider as a confounder.
Thank you. Thank you very much.
Thank you, Dr.
Yeah, so thank you all. And with that, we come to the end of this session. Thanks to all the presenters for their wonderful research work and brilliant presentations, and to the judges for their comments and scoring. I request all the judges to complete the scoring, and you can mail the same to Dr. Sushmita, the secretary, for the compilation and results. And I hand over the session now to the faculty of the next session. The session is on recent literature from India, to be moderated by Dr. Shanta and chaired by Professor Ramanjit Sihota Madam, and convened by Dr. Manju Pillai. Thank you all.
Good evening, everybody, and thanks for the invitation. So it is my pleasure to introduce the next keynote speaker, Dr. Anil Mandal. He has been a pediatric glaucoma specialist with more than 30 years of experience, has over 150 publications in this area, the first ophthalmologist to receive the Shanti Swarup Bhatnagar Award for research in pediatric glaucoma in 2003. He also received the Senior Achievement Award in the American Academy of Ophthalmology in 2008, delivered the Noel Reyes Lecture in the United Kingdom Pediatric Glaucoma Society in 2019, and the Adanwala Award in the AIOC 2022. So without much ado, we'll go on to his talk on congenital glaucoma going forward by looking back.
Thank you, Dr. Santa. Down. Down. Thank you. The title of my presentation is Caring for Children with Glaucoma, Going Forward by Looking Back. The passing of time creates a great opportunity to look backward and to look forward. Past, present, and future is the continuum of time. The present is the daughter of the past and the mother of the future. It is imperative to know what has happened in the past in order to understand what is happening and what is going to happen. We must keep in mind that our current sophistication in the management of pediatric glaucomas will, in a few short years, be regarded as rather primitive and outdated. So, only by a knowledgeable understanding of the past will we come to appreciate and benefit from the present and may help create a base for the future. It is with this idea this presentation was planned. In my presentation, I would like to give a broad perspective on my journey of 30 years. While reflecting on my journey of 30 years, I would like to give the milestones of my development and learning. To my good fortune, I had the opportunity of 6 happy years centered around Dr. Rajendra Prasad Center for Ophthalmic Sciences at the All India Institute of Medical Sciences, which recruited and developed a fine faculty and always emphasized the residence training as the top priority. Professor Sood, Professor Agarwal, and Dr. Ramanjit Sihota was in the faculty when I was doing my senior residency from 1987 to 1990. In the year 1990, I joined LV Prasad Eye Institute, and since then, I am working continuously on this disease, the pediatric glaucoma. Now, when I joined RP Center as a junior resident in 1984 January, we came across this paper presented in Indian Journal of Ophthalmology by Professor Sood. Professor Sood started his surgery of primary combined trabeculotomy, trabeculectomy since mid-1970s. And 1983, he presented the first paper and concluded that this is the safest and most effective in controlling intraocular pressure in children with glaucoma we see in India. After about 10 years, we collected the entire publication on this disease and summarized in the form of a review article in Indian Journal of Ophthalmology. Very interesting. In the very next year, in British Journal of Ophthalmology published an editorial where Dr. O'Connor commented that this technique may represent the next step in the search for the best surgical treatment of congenital glaucoma. In the very first decade of my work, we concentrated on this surgical technique, primary combined trabeculotomy, trabeculectomy in various cohort of patients, including secondary developmental glaucomas like Sturge-Weber syndrome. In refractory glaucoma, pediatric glaucoma, trabeculectomy with mitomycin C, we tried with great precaution. And in the extended series of patients, we received good results. These publications were included in the 7th edition of Baker-Schaeffer's textbook of glaucoma. Interestingly, before that, the mention of these two surgical techniques was not there in the literature. This is for the first time combined trabeculotomy, trabeculectomy, and use of mitomycin C was introduced into the literature and then came into the textbook. We continued the journey in the second decade. Safety and efficacy of simultaneous bilateral surgery was evaluated. It is safe. We evaluated the same surgical technique on newborn onset glaucoma and early onset glaucoma within 6 months of birth and get good result. Difficult situation where corneal diameter is more than 14 millimeter were also treated by primary combined trabeculotomy, trabeculectomy with good result. The first 15 years results were published in the journal Eye, where we concluded that it is safe and long-term results are good, and 42% of the patients gained normal visual acuity. One interesting thing, one serious complication of cardiopulmonary arrest happened in one patient in the examination under anesthesia, but not in the primary surgery. After 2 months of primary surgery, a 4-month-old child developed cardiopulmonary arrest and was successfully resuscitated. And just to tell you the fact that this child required intracardiac adrenaline injection to revive, and then the child was shifted to the intensive care unit in the city. World Glaucoma Association Childhood Glaucoma Research Network conducted a consensus survey, and we were part of that. And we continued our journey with this surgical technique in different other diseases like Axenfeld Rieger anomaly, primary congenital glaucoma, where the infantile onset glaucoma presented with acute hydrops were treated. This is the world's largest series on this rare manifestation with good result. From the very beginning, we realized that there is need for creating an association for the parents and children of congenital glaucoma. Here is such an gathering, and our founder director, Dr. Rao, is addressing the gathering. And one patient, I'll come to his story later on in the presentation, talking in the forum. We addressed several concerns from our side, and more importantly, listened to the parents and the children who could express their problem and acted accordingly to improve the quality of care. What we wanted to do was a whole person model of care for children with glaucoma. We realized that reduction of intraocular pressure is the first step, and then restoration of corneal clarity. And then our main aim is to improve the visual function. The ideal goal is stereoscopic binocular vision, so that the quality of life of the children will be maximized. That is the final goal. We worked on the quality of life of the caregiver and the quality of life of the children afflicted with congenital glaucoma. Caregivers of children with congenital glaucoma, CAR-CG QL questionnaire is a 20-item questionnaire. It is very simple and easy to adopt. and we employed in the patients and realized that there is significant change, large change from the preoperative and at the end of 6 to 8 weeks postoperative. We evaluated the quality of life of the afflicted children with congenital glaucoma. Despite undergoing successful glaucoma surgery, children with PCG reported reduced health-related quality of life. Very interesting thing, we evaluated the response of the patients and the parents, and that is discordant. And it is important that we take, cognizance of both the answers. Now, results of children treated with primary congenital glaucoma and glaucoma associated with secondary developmental glaucoma, we realize that there is quality of life is significantly better in children with primary congenital glaucoma. Our journey continued, and at the end of my career here after 30 years, I see that there is tremendous change happened. With immense pride and humility, I bear witness to the revolutionary changes that has happened in the field of surgical treatment of PCG in the past 3 decades. When we joined RP Center and then joined at LV Prasad, these are the surgical techniques known. Later on, all these surgical techniques were employed. But most important thing, this is very revolutionary change, particularly fiber optic microcatheter trabeculotomy in the management of congenital glaucoma, which is now the gold standard in the Western world. Because of obvious reason for the cost and the availability of the catheter, microcatheter, we still believe that in our patient population in India, with the moderate to severe degree of glaucoma, primary combined trabeculotomy, trabeculectomy is the way to go. Consensus survey by Childhood Glaucoma Research Network revealed in the year 2013 that CTT is the procedure of choice by only 14% of the experts. The situation has changed. I'm sure more number of surgeons are now realizing the potential of primary combined trabeculotomy, trabeculectomy, and using this procedure in the difficult situation. We recently published a large series of this in the journal. 1,128 eyes of 653 consecutive children were analyzed who were operated by a single surgeon, and the success rate of 75.5% at the end of 5th year reduced to 56% at the end of 10th year. Patients who presented with corneal edema did relatively poorer compared to the patients who presented with clear cornea. Giving some example, here is the child, advanced stage of the disease, but presented at birth. We operated at the 2nd week of the presentation. Simultaneous bilateral CTT was performed, and the child completed 27 years of follow-up. You can see the appearance of the girl at the end of 27 years follow-up. This child completed 30 years of follow-up. Simultaneous bilateral CTT was performed. Because of early intervention, his refractive error required, refractive status was normal and does not require any spectacle correction, etc. We recently published our results, and it shows that quality of life and life satisfaction of treated patients with primary congenital glaucoma during the adult life are generally good and appears to be driven by factors other than clinical indices. Educational achievement appeared to be linked to better quality of life and satisfaction. And so we, the clinicians, should emphasize the importance and the need for education in the continued care of these patients. Here is the diagram showing the professional achievement and educational achievement. Just to give a snapshot of till now, of all the patients we operated, 7 are doctors, of which 5 are postgraduate doctors, 5 PhD students, and 13 patients completed dentistry and practicing. So many patients are teachers, engineer, lawyer, journalist, chartered accountant, and doing their own business. Now, here is the other side of the story, more difficult side. We understood that the child's right eye is very severe, And in the left eye, we operated on both eyes with the telescopic magnification. The child completed study, became doctor, and is doing psychiatry postgraduate education in Bombay and in the final year. Over the years, we created an integrated management system, integrating child's medical, surgical, genetic, and rehabilitation approach. And that's the way to go. I have not voluntarily included much information about the genetic study. We have included more than 800 pedigrees so far, and working our geneticist along with us working on this disease. The idea is to make each and every afflicted child a contributory member of our society. And for that, parents' involvement are equally important, and a compassionate commitment from the part of each and every member of the healthcare team is essential. Just giving some example from my practice. Here is a child presented with mild form of congenital glaucoma at presentation. This is story of 1993. In spite of my best effort, I could not elicit smile explaining that the child should be okay because of mild form of the disease. But what happened after 2 months is, without any provocation, they smile because the child's cornea cleared and the child is responding to fixation very well. I continued the follow-up for about 27 years. Here is the child. I have had the opportunity to attend the marriage ceremony of this girl, and after 2 years, this couple were blessed with a perfectly healthy baby girl without any congenital glaucoma. Giving 2 examples, both these patients. The first example is this girl who was seen in LV Prasad in the year 1988 and was referred to Professor Sood for the management. I was doing my senior residency, and I took care while the child was admitted for the operation and management. Later on, in mid-90s onwards, the parents are coming to us. The child was having very poor vision, practically no vision in the right eye, and in the left eye with 2-meter vision. The child completed 12th standard with 94% of marks and completed BCom and business administration course and looking after her father's business. Got married. There was tremendous apprehension on the family. What will happen to the coming child? The child was perfectly all right, and the child completed 4 years of follow-up. Absolutely no problem. Yet another example. This is the child seen at LV Prasad while I was doing my senior residency with Professor Sood. In the year 1989, this child, whose parents were having consanguineous marriage, and the first child was having congenital deafness. This is the second child had congenital glaucoma. With my inadequate knowledge, whatever I explained, the genetic basis of the disease, I just conveyed if consanguineous marriage can be avoided in the family in the next generation. And because this was milder form of the disease, I also explained that the child should be okay. And I also explained that I'll be in the profession, I'm interested in congenital glaucoma, I'll take care of the child future follow-up. That exactly had happened after I shifted to LV Prasad Eye Institute, Hyderabad. Mid-17 onwards, the child, parents are bringing the child to here in LV Prasad, and to my surprise, presented the 3 photographs in the middle. This is an imaginary photograph. The parents are imagining that the child is becoming father of a healthy child, and here is the 2 photographs. They imagine they're only a child in different roles, bridegroom and bride and a father of a healthy child. Here is the child seen in 1990, 2016, got married. I had the opportunity, along with my wife, I attended the marriage ceremony, and here is the couple, the girl, the wife, and this man, blessed with a perfectly healthy, normal male child. And this is the story. When I reminded them about the past story, they were smiling and holding the child. I had the feeling that sharing once again in the wonder of birth, life comes to a full circle. I am yet to see this second child. The whole family is relocated to Toronto, Canada. This child was born on 3rd of November, perfectly normal girl child. And here is the child along with the parents and grandparents. I'm yet to see this child. So what I wanted to tell that this story was published in the newspaper in 2001, where I promised all these things, and this story was written, and all the things came true. Thus my prayers were granted, predictions came true, and I kept my promises. That's all I wanted in my life and in my profession. While taking care of the children who are having severe form of the disease and visual disability, I felt that there is a few key points on quality of life things: the activity limitation, the health concern, the emotional well-being, the symptoms, and the coping mechanism. Coming to the story of Rajesh, let us hear from Rajesh narrative.
Hi everyone, this is Rajesh from Hyderabad. I came to LV Prasad at the age of 5 to undergo treatment for glaucoma. Dr. Anil Kumar Mandal has taken care of me. He treated me from last 35 years. Today I'm 38. He advised me to the rehab at the age of 7 or 8, where I got a telescope to read my blackboard to start my education. Prior to it, I was totally zero. With the help of telescope, I was able to complete my Masters of Computer Applications. Today, I'm a bank employee working at Bank of America as a database administrator. I'm married. I'm 38 years old. I have 2 kids. So with glaucoma, I lived for 35 years. If Dr. Mandal has not advised me properly, has not taken care of me, I might have really left alone in dark room. He is the first person who encouraged me to get into computers if you are really interested. With his words, I started studying Bachelor of Computer Applications, then to Master of Computer Applications, then got an opportunity to work at Bank of America. He cared me like that he's really looking through my eyes. He cared to that extent. He made me to feel my life. If he is not there next to me that day when I was 5 years old, I can't even imagine my life to the extent I'm living today. I'm living comfortably with more benefits or all the opportunities which I am utilizing today. I sincerely thank Dr. Anil Kumar Mandal for making my life feel better and experience better and live luxuriously. Thank you. Hi everyone.
So giving yet another example, this girl, we tried our best, presented at the second week after birth. Very severe form of the disease, multiple surgery was done, including penetrating keratoplasty. All failed. At some point of time, we realized thus far and no further surgery. And we took help of rehabilitation department. Just listen to the story of this girl. She's a good singer. Hi Monica.
Hello sir.
Hello, how are you?
Yeah sir, doing great. How about you sir?
Yeah, I'm doing fine. So you remember, madam remembers very well. Both of you are coming to us regularly for last almost more than 20 years.
Yes sir.
About our treatment. We tried our best, but the situation is like this. We explained the situation. And you completed your schooling and 12th standard. What you are doing now?
So I did my schooling from Devna Foundation for the Blind, and from same branch of Devna, Sai Junior College, I have completed my 12th standard. Now presently I'm undergraduate. I'm pursuing my second year from Koti Women's College, Osmania University, BCom Computers.
Alright, BCom Computers.
Yes.
So you are very much interested in learning computers.
Yes sir, very much.
What do you want to be in future? What do you want to be in the profession?
Actually, my passion is my passion for music is very big, I say.
Yeah, I knew that.
Yeah, so I would like to become a singer as well as a PO in SBI, professional officer in SBI. Gana cheturaya, gana pranaya, gana taratmani, gana utsukaya, gana
Monica,
Sir.
so we explained the situation to you and to your mother also, that we tried our best, but this is difficult. As of now, you are having light perception only. How you feel about it?
Sir, so in my view, eyesight is not an important thing, sir. The attitude which we have is very important, and the goal which we reach is very important, sir.
Yes, so it's a very philosophical, very hard lesson in life. Eyesight is important, but more important than that is the attitude.
Yes, sir, of course.
Attitude in life, positive feeling about everything. And you are an example of that. You are doing excellent.
Thank you so
Best
much.
of luck with your career, with your future. Interacting with this girl, I got reminded of the statement of Helen Keller, where she said that only thing worse than being blind is having eyesight but no vision. Look at the girl, the confidence, the vision she has for herself, for the future. Friends, we should be able to share our experience. Experience is the teacher of all things. The only source of knowledge is experience, as said by Einstein. You cannot create experience, you must undergo it. Experience is not just what happens to you, it is what you do when it happens to you, what happens to you. Some people say that experience.
Hello, Dr. Mandal, I think we are a little short of time.
Yeah, I'm finishing in 1 minute. So this is the experience, and we should be able to transfer the skill, knowledge, and experience to the next generation. I am very fortunate to have Professor Sood as my mentor. Having a coach or mentor like Professor Sood is like sharing life's experiences. No amount of education can substitute true life experience. Wisdom is the reward of experience and should be shared. From time to time, I shared my work with Professor Sood and got his blessings and guidance. And I dedicate this lecture in the memory of Professor Sood and Dr. N.N. Sood. I just wanted to conclude my talk with an appeal. As a robust and unified global community of pediatric glaucoma specialists, we should strive with courage, conviction, and curiosity to create a better solution for the management of PCG. And we want to see every child.
Thank you, Dr. Mandal. I think that is such a inspiring talk, and I think we hope that this society will encourage more and more people to take a greater interest in pediatric glaucoma. Thank you so much.
Thank you. Thank you.
Thank you, Dr. Mandal. I think since we are running short of time, we'll go straight to the 6 papers which have been published by our pediatric glaucoma specialists from India. We have 6 papers, and our discussants will be Professor Gren, Dr. Brooks, and Professor Khan. The first paper is again Dr. Mandal's. He will be speaking on outcomes of management of glaucoma and phakomatosis pigmentovascularis over the last 3 decades.
Time, Dr. Mandal.
Yes. This is a paper which is published last year, Outcome of Management of Glaucoma in Phakomatosis pigmentovascularis. It's a very interesting story behind it. This is the typical presentation of a child with advanced form of the disease with manifestation of glaucoma at birth. I came across this child in the year 1997 when our retina surgeon referred this child to me. I felt that it's a combination of Sturge-Weber syndrome and dermal melanocytosis. And I was so enthusiastic that I felt that I should publish this as a new syndrome. Little did I know that this syndrome was published approximately 50 years ago. and in the Japanese Journal of Dermatology, where Ota presented the first presentation, and few cases of this clinical picture was presented as early as 1910 in different dermatology literature. About 50 years for the knowledge to come from dermatology to ophthalmology. Ophthalmology 1997 published a series of patients from Bangkok, Thailand, a series of patients with phacomatous pigmentovascularis. The first patient we saw completed about 27 years of follow-up here, and this is the manifestation of the right eye. 55 eye of 38 children were analyzed. Few patients, because of less follow-up less than 1 year, was excluded. 8 from the bilateral group and 6 from the unilateral group. The problem of management of phacomatous pigmentovascularis is very severe form of the disease, and most of the patients presented with severe degree of corneal edema along with megalomania. We tried combined trabeculotomy on 13 eyes, and 10 patients who had history of previous surgery were managed by trabeculectomy with mitomycin C, and 4 no visual potential and the pressure was high. The visual outcome is listed here. Visual outcome is not good compared to the primary congenital glaucoma. I'll show some picture. This is a patient, bilateral affliction with severe dermal melanocytosis. Yet another patient, you can see here, unilateral affliction, left side with dermal melanocytosis. It is the left eye which was afflicted. We operated, and just compare and contrast pre-operative and 6 weeks post-operative appearance of the child. And the child's intraocular pressure was controlled. The child completed about 15 years of follow-up, and you can see here the left eye was operated and the bleb appearance of the left eye with combined trabeculotomy, trabeculectomy. Very significant improvement in the corneal clarity, intraocular pressure control, and the child is completed 15 years of follow-up. Very interesting observation that the density of melanocytosis has decreased significantly over a period of 15 years. Yet another child where right side was involved and we operated. The child is doing very well, completed 12 years of follow-up. There is the child seen at the age of 12 years. This is yet another child who completed about 10 years of follow-up. So just to conclude, phacomatous pigmentovascularis is a disease which is more common in the pigmented race, relatively rare in Caucasian population, but rare cases are there. Primary combined trabeculotomy, trabeculectomy probably be the primary choice of surgery when we are operating for the first time. In difficult situations, trabeculectomy with mitomycin C is an option. Tube implantation is an alternative. And in a difficult situation with very poor visual potential, transscleral psychophotocoagulation should be performed. But concluding remark from my side is, these are difficult patients compared to primary congenital glaucoma, very refractory in nature and requires more rigorous surgical treatment and meticulous follow-up. Thank you.
Thank you, sir. We have 2 minutes time for discussion. Any comments from the discussants?
From my side, I would like to know in how far choroidal hemangioma, the presence or absence, would influence the type of surgery you propose in these cases.
Yes, a very interesting question. The question is, where combined trabeculotomy, trabeculectomy was done, most of the patients' corneal edema was so severe that we could not examine the fundus with indirect ophthalmoscopy. We had to depend on ultrasound B scan, where ultrasound B scan detected choroidal hemangioma. We were very careful in explaining the possible side effects and the intraoperative and immediate postoperative complications of the management. And then we went ahead. In our series, few patients developed choroidal detachment, subchoroidal effusion, serous effusion, were managed conservatively and became all right.
Any
Even
other
if you do a combined surgery, you can still do it in the presence of a choroidal hemangioma. So I think the severity of the glaucoma determines the surgery more than the presence or absence of the hemangioma.
Yes, yes, madam.
And,
So
and
you
Dr.
said-
Mandel,
Sorry,
Dr. Mandel, do you alter your surgical technique in these sorts of cases compared with primary congenital glaucoma to try and prevent any rapid decompression of the eye?
Yes, in primary congenital glaucoma, even primary congenital glaucoma, we used to do the surgical technique, the trabeculotomy part and the trabeculectomy part we used to do, and we used to prepare ourselves and this whole surgical team and the nursing staff who is assisting that trabeculectomy and the iridectomy part and the closure of the superficial scleral flap is done very quickly, very meticulously and very quickly, because whenever there is choroidal hemangioma, or for that matter, advanced stage of developmental glaucoma, possibility of development of intraoperative choroidal effusion of subchoroidal hemorrhage, it will take some time. And the idea, my impression, my idea is to do the surgical technique in a way, by the time the sequelae develops, we are out, we are completing the surgical technique. That's the way I plan.
thank you, sir. I think we've run out of time for the discussion. So can we go on to the next paper?
Thank you.
So is my screen visible?
Yes, sir. Please go ahead.
Thanks. So I'll be talking about this work of ours where we found association of PLOD2 gene in primary congenital glaucomas and juvenile glaucomas. So the genetic association of primary congenital glaucoma, which has been linked to certain genes, together explains only about 40 to 80% of the cases of primary congenital glaucoma, depending upon the population that is being studied. So in certain populations, the frequency of these known mutations in these known genes is high, whereas in other populations it is low. So there is one study from India that found that out of 300 primary congenital glaucoma cases, the CYP1B1 mutations were seen only in about 43% of the cases, and majority of the patients, the mutations were not known. So this story actually started about 11 years back when these two kids with who were monozygotic twins came to me with bilateral congenital glaucoma. Both these kids had very large corneal diameters, 14 millimeters and above, high intraocular pressures, and surgery was done to control the intraocular pressure. At that time, we could take their blood samples and we did screen them for CYP1B1 mutations, but we did not find any CYP1B1 mutation in these two kids. So over the years, we had access to funds and we started doing genetic sequencing for a lot of our juvenile glaucoma patients. And that was the time when even these two kids, their samples were sent for whole exome sequencing, and we screened for all the known genes available for glaucoma, but we couldn't find any of those that were either directly or indirectly associated with glaucoma to have in these two kids. So what we found was that both of these twins had a deleterious mutation in the PLOD2 gene. Now, this gene is also known as the lysyl hydroxylase gene, which codes for a collagen formation. So therefore, it is important in the stability of collagen. And there were deleterious mutation in both of these monozygotic twins, which were absent in either of the parents and in an older sibling. So what we did was to confirm the presence of a PLOD2 mutation as causative. We looked on, among our juvenile open-angle glaucoma cases, and out of 40 such cases, one patient with a sporadic onset of juvenile open-angle glaucoma also was found to harbor the PLOD2 mutation, which was different from that we saw in these two kids. So among the variants that were associated with glaucoma in these monozygotic twins and this GOAG patient, we found the NF1 gene, the PAX6, and the optineurin gene, but all of these variants were benign. So obviously there was something related to the PLOD2 gene, which was causing glaucoma in these individuals. Now, the PLOD2 gene is actually has about 18 to 19 exons, and in both of our cases, we found mutations in exon 17. And both of these mutations are highly conserved in the evolutionary process, which means that they are very important, apart from the fact that they were pathogenic and caused a disturbance in the protein functioning of this gene. Also, what we found was that the PLOD2 gene exists in the 3q24 region, which is also the locus for the GLC1C for glaucoma. That means this particular locus, the genes have not been identified, yet it is considered to be associated with primary open-angle glaucoma. And since PCG, juvenile and adult onset open-angle glaucomas form a continuum, there is a possibility that the PLOD2 is not only associated with primary congenital or juvenile glaucomas, but it would also be associated with adult onset open-angle glaucomas. The PLOD2 gene, the PLOD2 is primarily associated with osteogenesis imperfecta and what is known as the Bruch's syndrome. None of our children or the juvenile patient had any orthobitic abnormalities. But then there is another interesting feature is that the PITEX2 gene, which is known for Axenfeld-Rieger's, also regulates the PLOD2 function, which means that the PITEX2 gene associated with Axenfeld-Rieger's could be associated with some form of angle dysgenesis, which could also be related to the PLOD2 expression in the human eye. And if you look at the PLOD2 and the PLOD1 family of genes causing Ehlers-Danlos syndrome, which is also a form of osteogenesis imperfecta, and you compare it with Rieger syndrome, which was done in one study, they found that a lot of features, both ocular and non-ocular, were quite similar, which means that there is some amount of dysgenesis which is associated in the angle in osteogenesis imperfecta, leading to glaucoma, as well as that associated in Rieger's syndrome. So probably this gene lies somewhere in the pathway which is involved in the development of the angle. So we did certain zebrafish experiments where we did in situ hybridization to look for expression of the PLOD2 gene in the eye, and it was highly expressed in the eye. We also injected morpholinos, which were knockdown experiments in the zebrafish to look for the functionality, and we found that injecting the PLOD2 gene did result in a decrease in the immature formation of the eye. The maturation of the eye itself was impaired. So there is some role of the PLOD2 in the development of the eye, which is obvious. So therefore, we conclude that probably this could be a potential gene that needs to be looked for among cases of primary congenital and juvenile glaucoma patients where no other gene mutations are known. We still need to replicate this in larger number of studies, primarily because the prevalence of this mutation is still low. And we are going through with our functional studies to establish the cause and effect relationship with regards to glaucoma. So apart from those people who helped us as our authors in the paper, I must acknowledge this, the work of our optometrist, medical social worker, and a whole team of biologists at the ICER who helped us with all of these experiments. Thank you.
Thank you, Dr. Vinay. We can have some questions now. Professor Arif, you have any comments?
Yeah, thank you. Very interesting work that you've gotten involved in there. Those were monozygotic twins. So it was actually as if they were one individual. So it wasn't really finding the variant in two, it was really finding it in one, and then that other individual from your cohort. It's very interesting, but again, you know, these things are hard to prove unless you can demonstrate it in different populations. One of the tricky things is that, you know, these variants don't work in isolation, and sort of like was alluded to the other presentation, which you were part of. You know, there are patients who have PAX6 mutations that really are PAX6 mutations, and they don't get classic aniridia, and that's related to their genetic background. So maybe there's something in addition in the genetic background of the patients with these variants that's causing them the glaucoma. These gene variants don't act in isolation; they act in the background of the rest of the genome. So it's very interesting work, and sure, there are some clues there that there's something going on here, but it's always difficult when there's not a large number of patients to convince people.
True, I agree totally. Yeah.
But
Thank you.
It's great work. Great work.
Any other comments? We can have the next paper coming up while any further questions can be brought forth.
These patients were, I mean, these patients these patients were juvenile glaucoma from different regions in India, or were they from the same region?
So among the juvenile glaucoma population, most of them were from North India. But what was interesting was that the juvenile glaucoma patient was also sporadic, means there was no familial component here. Neither was there in the monozygotic twins. So
yeah, the monozygotic twins is actually is a sporadic case, actually.
Yeah, yeah. So therefore,
it could be a very rare cause. Yeah.
Absolutely. Yeah. Yeah.
Mr. Rahul, could you share the next presentation? Dr. Sirisha Sentals.
Hi, friends. So I'll be discussing the surgical options that are there in the management of Axenfeld-Rieger syndrome. As we know, this is a rare autosomal dominant disease characterized by abnormal iris.
This is tomorrow's talk. Today's is the PK. Yeah, this one, the next one. Thank you.
Could we start, please?
Yes.
Sirisha, do you have can you share your screen and
Sirisha, he says it's not a video. Is it a PowerPoint?
So it's a video.
Rahul, it's a video.
Plastic world.
Maybe we can go to the next talk.
Yeah, could you share the next talk? That is comparative evaluation of rebound and Perkins nanometers in pediatric glaucoma.
Dr.
Yeah. Okay, doesn't matter. Can you go on to the next presentation? The fourth one, Dr. Devana.
Yes, ma'am, I would be sharing my screen for that. Good evening, everyone. Is my screen visible?
Yes. Yes, it is.
At the outset, I would like to thank IPGS for giving me the opportunity. I would be speaking on comparative evaluation of rebound and Perkins tonometer in pediatric glaucoma with varied corneal characteristics. So as we all know, Goldman applanation tonometer is the gold standard for IOP measurement, and Perkins is based on this principle and can be used in supine position, especially in children when undergoing examination under anesthesia. IOP measurement using Perkins is difficult as the children always have to be sedated or should be under anesthesia. Vis-a-vis eye care tonometry, which is based on the principle of rebound tonometer. It is fast with minimal contact area and does not require any anesthesia, making this a good technique to be used in children. And more so, eye care IC200 can be used in supine position, making it a more versatile option. So as we all know that COVID had set in and there was a lot of difficulty in getting these patients examined. So the primary objective was to compare the IOP measured using eye care IC200 with Perkins tonometer in pediatric glaucoma patients with clear cornea and patients having corneal haze or corneal scar. Our secondary objective was to measure the demographic details, corneal characteristics, corneal diameter, and to correlate with the difference in intraocular pressure. It was a prospective cross-sectional study, and 200 eyes of 105 consecutive glaucoma patients undergoing examination under anesthesia were enrolled. Informed consent was taken and inhalational anesthesia was used for all children, and the readings were obtained within 5 to 10 minutes after inducing the patients. The IOP was measured by the eye care tonometer followed by Perkins tonometer by a single observer in all our patients. The characteristics of the cornea was noted for all patients depending on the visibility of the iris details as clear cornea, corneal haze or edema where the details were partially visible, and corneal scar where the details could not be appreciated. The central corneal thickness was measured using ultrasonic pachymeter, and we included patients with age less than or equal to 12 years and a diagnosis of primary or secondary developmental glaucoma. We excluded all patients of post-PK glaucoma and patients having repaired post-traumatic open globe glaucomas. So out of the 200 eyes, 3 eyes post-PK glaucoma was excluded from our study. The mean age was nearly 45 months, and our diagnosis was most 70% constituted of primary congenital glaucomas. So the IOP measured by the Perkins versus the eye care had a higher IOP versus the Perkins, and the mean central corneal thickness was 670 microns. So if you look at the difference in IOP between Perkins and eye care was 0.65 millimeters of mercury, and on blunt alternate plot there was a wide limits of agreement. If you look at a subgroup analysis wherein 124 eyes were in the clear cornea group, 36 in the corneal haze group, and 34 in the corneal scar group. If you look at the corneal diameter and the corneal thickness, it was much higher in the corneal haze and the corneal scar group as compared to the clear cornea group. And the Perkins IOP versus the eye care IOP, there was a difference between the two, and it was higher measured with the eye care tonometer. And coming on to each subgroup, in the clear cornea group, the difference between the two tonometers was 0.59 millimeters of mercury, and there was a wide limits of agreement in the blunt alternate plot. In the corneal haze group, again, there was a difference of nearly 0.47 millimeters of mercury, and the correlation with the two tonometers was 0.94 with a wide limits of agreement. However, in the corneal scar group, the difference between the two tonometers was nearly 2 millimeters of mercury, which was statistically significant, and there was a wide limits of agreement on the blunt alternate plot. On doing a further subgroup analysis depending on the IOP, where we had sub-analyzed as IOP of less than 19 millimeters of mercury, this included nearly 66% of our patients versus patients having IOP more than 19, which included 34% of our patients. The difference between the Perkins and eye care in patients having IOP less than 19 was 0.47 millimeter of mercury, whereas in the IOP more than 19 millimeters of mercury, it was nearly 1 millimeters of mercury. And we also did a further subgroup analysis based on the central corneal thickness. The median central corneal thickness being 615 microns was taken as a cutoff. The difference between the Perkins and eye care in the CCT group less than 615 microns was 0.32, whereas in the CCT group more than 615 microns was nearly 1.12 millimeters of mercury, which was statistically significant. The Perkins and eye care IOP had a slight positive correlation with the corneal thickness in the clear corneal group. whereas it had a very strong positive correlation in the patients having a corneal opacity or a thicker cornea. So there have been various studies in the adult patients that show a good correlation between Perkins and eye care. However, in pediatric glaucoma patients, there are very limited studies. A study by Sands et al. Noted that there was a good linear correlation between the eye care and the Perkins, and 64% cases, the difference in IOP was less than 3 millimeters of mercury. Another study by Martinez et al. Also noted that eye care overestimates the IOP in comparison to Perkins in congenital glaucoma, and the difference in IOP becomes larger as the CCT increases. Another study by Bartakre et al. Also noted there was a good correlation between the eye care and Perkins, but the limits of agreement were wide, and the difference in IOP was definitely more in IOP more than 19 millimeters of mercury. In our study, we showed that there was a good correlation between the two tonometers, but there was a wide limit of agreement. There was an overestimation of IOP by eye care, which was more so in eyes having corneal opacity or patients having a corneal thickness more than 615 microns, and patients having an IOP higher than 19 millimeters of mercury. The limitations being that we had a small sample size, especially pertaining to the different subgroups. Also, the study was done on anesthetized children, and therefore the compliance and the ease in measuring IOP using the eye care in patients without anesthesia could not be evaluated. So to conclude, I would like to say that eye care is a good alternative to Perkins tonometer in pediatric glaucoma. However, in eyes with corneal opacity having thicker corneas and IOP more than 19 millimeters of mercury, the IOP readings should be taken with a pinch of salt, and it should be rechecked with Perkins tonometer before doing any changes in the management. Thank you for the patience.
Professor Gren, would you like to comment on the paper and offer your suggestions as to which tonometer we should depend on?
Yeah, as you heard in my lecture, I favor the eye care tonometer because of the practicability to use it in unanesthetized children. But if we also do, of course, both measurements during routine examinations under anesthesia. And my personal view is that the practicability of the eye care is, even in the situation of an operating room, is easier. And therefore, the major problem is whether we can rely on the eye care tonometer values when the values are relatively high, because, as you said, it's overestimated. But my view is that if it comes to patient for surgery, it's a yes or no question. And if you have descemeters, extended globe, changes in the optic disc, yes or no. But if there are descemeters, this is such a clear sign, then that is my number one for decision and my number 2 or 3 for decision. It's very important to know the differences between the two tonometers. But finally, for the future, I assume as to non-anesthetized pressure measurements, we will also shift to ballistic tonometry.
So would you base your clinical decision making on the eye care tonometry readings if you had to change your medications or take a decision to operate? Would you shift over to the Perkins?
No, I think it doesn't matter so much whether the tonometer reads a little bit higher or lower values, as long as you use the same tonometer, because what you really need for decision is the mean and not the absolute value.
So we would depend on the other clinical parameters to take a decision, actually, not the pressure measurements.
Indication for surgery, I think it's very important to look to the eye as a whole, especially on descemeters. For the question of changing therapy, it's the change of pressure that would trigger for me some decisions.
Thank you so much. We have the next paper ready. Sirisha, are you ready, or shall we go on to Dr. Sushmita's paper? Mr. Rahul, which one do you have ready?
I can share my screen if Sirisha is not done here. Sirisha is out, so it's visible now.
Yes, it is.
Yeah, okay. Right. Thank you very much again. And I've thoroughly enjoyed this evening of pediatric glaucoma. So I'm going to talk about something that we've observed, neonatal onset congenital ectropion UVA. And we realized that it's a distinct phenotype of newborn glaucoma. So a neonatal onset glaucoma really is an umbrella term of patients who present with glaucoma before 1 month of age. And PCG is easily the most common phenotype, as we also saw in another recent publication. But any anterior segment dysgenesis could present in the neonatal period. So we've observed that there is in a subset of neonatal onset glaucoma, which really didn't fit into one of the standard anterior segment dysgenesis pictures, a bilateral ectropion UVA with varying degrees of iris hypoplasia, and they appear to have a poorer prognosis compared to neonatal onset PCG. And literature search on CEU describes CEU in older children as a unilateral glaucoma with mild ptosis, CEU, often associated with neurofibromatosis. And we were unable to find any report of bilateral neonatal onset CEU presenting as newborn glaucoma. So the purpose of our study was to prospectively observe the incidence, presentation features, and outcome of CEU in newly diagnosed newborn glaucoma and compare the outcome to neonatal onset PCG. We had ethics committee approval and we took informed consent to use these pictures. So this was a prospective clinical cohort study of consecutive patients with neonatal onset glaucoma presented in a 15-month period with a minimum post-op follow-up of a year. And any ocular anomaly apart from CEU were excluded. All infants underwent goniotomy or trabeculotomy, with trabeculotomy depending on corneal clarity. The outcome measures, we compared neonatal onset CEU with neonatal onset PCG and looked at an outcome 1 year after surgery. We took pressures of less than 16, rather tight criteria for 16 under anesthesia, without or with topical medications to be a total or complete or qualified success. And if the infant required an additional surgery, we termed the outcome of the first surgery as poor. So we saw 28 neonatal onset glaucomas during that period, of which 12 were neonatal onset CEU and 10 were neonatal onset PCG. And in fact, other abnormalities were about 6. So we compared 19 patients with 1 year follow-up, neonatal onset CEU 10 and 9 of PCG. So these are the typical microscope pictures of the patients at presentation. Severe iris hypoplasia, sometimes misdiagnosed as aniridia, as we learned it wasn't aniridia. This CEU was visible, and the other thing is we've actually misdiagnosed them as neovascularization or neovascular glaucoma and wondered what it was. But we've now realized that these are just prominent normal iris vessels which are visible simply because the stroma is completely hypoplastic. And this is the CEU where we see the ectropion UVA through these eyes. So neonatal onset CEU had significantly worse corneal clarity. They had thicker corneas. Regarding surgery, 7 of 16 with the PCG could undergo a goniotomy, but only 2 of the 20 eyes, or 10%, could undergo goniotomy in the CEU eyes. And this is from our paper, where we can see the corneal clarity grade, the corneal diameter was similar, axial length was similar, but the main thing was a corneal clarity grade and the intraocular pressure. All other things were similar. So we had poorer outcomes in neonatal onset CEU, which was the hypothesis to start with. Only about 30% of eyes with CEU had a good outcome compared to 81% of neonatal onset PCG with that one surgery. And this is just to illustrate the kind of corneal clearing that we see in neonatal onset PCG if there's no other abnormality, whereas there are these persistent scars from the newborn period which persist until they're about 1 or 2 years old as well. So the IOP remained high. So even the glaucoma was more intractable. We don't know whether it indicates a more severe trabecular dysgenesis, But these are the IOP of the CEU eyes, and this is the IOP of the PCG eyes, and these are the corneal clarity which remained worse compared to the PCG eyes, which steadily became clearer with time. So what we learned really was that neonatal onset CU is distinct from the unilateral CU in older children and young adults. And this is a typical patient of that, the CU that is described in literature, this unilateral severe glaucoma, mild ptosis, presenting during adolescence. Compared to that, the neonatal onset CU were all bilateral severe glaucoma in neonates with poorer outcome than neonatal onset PCG. So all of our babies look like this. The closest description in literature was actually Professor Arif Khan's paper, where he considered this a distinct aniridia phenotype, but said that bilateral mild ectropion UVA with partial aniridia is a phenotypic feature of recessive CYP1B1 mutations. And these anterior segment findings, he went on to add, in a newborn need not trigger testing of any other anterior segment developmental gene. So he said that it's so phenotypically marking a CYP1B1 mutation. So obviously the next question was, do we have a common underlying genetic variance which results in this particular phenotype? And this went on to another paper which is online right now. And we actually saw a distinct CYP1B1 pathological variant in the neonatal onset CU. We had 13 more patients and 12 of them have actually CYP1B1 variants. And 9 of these, 83%, were homozygous for the same variant. So they were homozygous recessive. All of them had the arginine 390 histidine, which was seen in all of them. So to conclude, it appears to be a distinct phenotype, and it's a phenotypic marker for specific CYP1B1 genotypes. And in our cohort, we observed the p-arginine 390 histidine as common to cause this phenotype in our cohort. Thank you. I'd acknowledge all of these people, and all the children are our children, and the senior residents have taken on the role of being their parents with us. Thank you.
Thank you, Sushmita, for that very lovely presentation of a very unusual problem. Any comments from our panelists?
Yes, yes, of course. I of course love that work. I think it's great. You know, when I see that phenotype, I'm happy and I'm sad. I'm sad because it's very bad.
Yes.
And it's very difficult to deal with. But I'm happy because I know exactly what it is. You know, in my experience, it's not specific for a particular CYP1B1 mutation. We've seen different mutations that can cause that. And it just goes again to that issue of the genetic background. But maybe in the Indian population, is it the Northern Indian population?
Yes, in fact, it's Northwestern. And I just like to add that arginine P390 histidine has been described as a founder mutation in Pakistan, but they only called it congenital glaucoma. So for all you know, they might have missed the phenotype. So I'm not sure.
Well, this is the importance of careful phenotyping. I mean, this has been around for a while, but people haven't been paying attention, and they just, you know, cloudy cornea, and they're just doing the surgery. And so this is just the importance of phenotyping, so we know what we're dealing with. And we know that this is not the PAX6 aniridia where we have to think about Wilms tumor in babies. So the power of phenotyping is there. This demonstrates it, and this is great work. I'm really happy to see it.
May I ask about the unilaterality? Why have you any explanation why that is only mostly in one eye?
The older CU has been described as a unilateral glaucoma. And interestingly, we've had 9 children so far, and all of them seem to have the left eye. Dr. Arif, if you could tell us why, because I could understand the ptosis because it's neuroectodermal problem. That's why they probably have the ectropion and the ptosis. But why should it be unilateral? Sir, I don't have the answer.
You're talking about the congenital ectropion UVI syndrome, the regular one?
The older one. But ours, Dr. Gren, are all bilateral, severe neonatal onset glaucomas.
Yeah, I'm talking about the elderly one, which I have seen mostly.
Yeah, that one, there's no genetic basis known for that. I mean, it's something happens in development. It's interesting about the eye side. I haven't noted that, but it's interesting if they're all the left eye. You know, we see Duane syndrome, a form of strabismus that is not from genetics. Typically, has no genetic basis, and it's usually on the left side also. So there must be something during development where the left side is just more prone to a perturbation, not necessarily from a gene mutation, something environmental. It's really interesting stuff.
Yeah, but as I showed, there was a child that had different phenotypes in either eye. One resembled.
Yeah, we see that in CYP1B1 mutations. I mean, we see sometimes one eye has Peters anomaly and the other eye has primary congenital glaucoma. One eye, it seems to be a unilateral case, but then years later, the other eye gets involved. So we can certainly see variable expressivity for CYP1B1 mutations. Even in this same patient.
It's only CYP1B1 where that happens, because in my example, it should be something different. It was either Peters or it was aniridia.
Your example was also CYP1B1.
No, not this one. This was not tested. That was many decades ago.
No, I think you showed a patient, one eye had Peters anomaly and the other eye had like an Axenfeld-Rieger type, and it was CYP1B1 that you showed on it.
That's true, but this is a different one which I showed before, where one eye had a opaque cornea and the other eye had something like Axenfeld-Rieger.
Yes.
And
I've come across a couple like that, Peters in one eye and Axenfeld in the other. I assume they're all Pitex2 or something.
Yeah, maybe. That's what I assume, but it was not tested. That was about 25 years ago or more.
Thank you. If there are no other comments, can we move on to the last paper? Dr. Vijaya Gotwal's, Mr. Rahul. The last paper, Dr. Vijaya Gotwal's Beyond Intraocular Pressure.
Dr. Shanta, thank you. I'll speak.
Oh, please go ahead.
Thank you, IPGS, for giving me this opportunity to share my talk. So the topic is Beyond Intraocular Pressure, Visual Ability and Vision-Related Quality of Life of Children with Glaucoma. As we all would agree, the goals of management of childhood are beyond reducing intraocular pressure and restoring corneal clarity. So more importantly, improve visual function and above all, maximize the quality. Now, why is this important? The management of childhood glaucoma is challenging because these children require lifelong follow-up. So it's a constant reminder of the disease, and they require anti-glaucoma medications both before and after surgery, causing a significant economic burden for the family. And in terms of symptoms, it's very discomforting for the child to use the medications. And in addition, the ametropia and amblyopia require monitoring and treatment, and the repeated EUAs are an unpleasant experience. In addition to all that, the cosmetic blemish that happens because of port wine stain and the corneal scars that are left, proptosis. So it affects the child's socialization, leads to isolation, and the nephrological issues that are associated with Wilms tumor, etc. Now, repeated surgeries are required more for secondary than for primary glaucoma, resulting in numerous hospital appointments. So these children frequently are absent from school, so it impacts their education. And the visual impairment is common, so it impacts the child's overall development, independence, social integration, and education. It is well established now that clinical measures such as intraocular pressure and visual acuity are only surrogate measures. They are an inadequate representation of the impact of disease on a person's life. And that is why these other patient-reported outcomes like visual ability or visual functioning, which represents the ability to perform visually guided day-to-day tasks, are important. And vision-related quality of life is an encompassing
entity, which is a multidimensional complex trait. It includes visual functioning, convenience, social relationships, concerns, symptoms, and emotional well-being. There is not much in the literature beyond as we all know, a lot of literature exists regarding the surgical and visual outcomes of children with childhood glaucoma, and there's not much that has been published in the area of vision-related quality of life. Therefore, our aim was to explore the visual ability and vision-related quality of life of children treated for primary and secondary glaucoma at our center since 1991. And in addition, also to investigate any relevant predictors of these in these children. So it was a prospective cross-sectional study. Children aged between 8 to 18 years who were attending school with either secondary or primary childhood glaucoma, and with minimum follow-up of 6 months. So we used the LV Prasad Functional Vision Questionnaire, which was developed about 2 decades ago and then was revised in 2012. It is a 23-item questionnaire, and it assesses the visual ability. Also use the impact of vision profile that is developed primarily for an Australian population, and it measures the vision-related quality of life. It is a 24-item questionnaire where higher positive scores indicate better vision-related quality of life. We validated it using rash analysis in our population prior to using it in the study. So the questionnaire was either self-administered or was administered by a trained interviewer, and we collected the clinical outcomes, the clinical indices, and the other data from the medical record. So the rash scale visual ability scores were calculated from the LVP-FVQ and from the IVIC questionnaire. For the visual ability or the LVP-FVQ scores, higher negative score indicates better visual ability, and for the vision-related quality of life, the higher positive scores indicate better vision-related quality of life. So we included, so as you can see, 53% of the children had primary glaucoma and 41% had secondary glaucoma. If you see, the mean age was comparable between the two groups. It was about 12 years, and there was a slight male preponderance in both the groups. But as expected, the duration of glaucoma was slightly higher in the primary glaucoma group, and the mean age at diagnosis was younger for primary glaucoma than for secondary glaucoma. And as a rule, mostly were bilateral. Obviously, the follow-up was higher in the primary glaucoma, and then more children were using one or more medications in those with secondary glaucoma than in the primary glaucoma. The median visual acuity was about 615 or 2050 in both eyes, in both the groups. And the the quality of life, overall quality of life was rated very good or good by close to 3/4 in primary glaucoma and about a little over 2/3 in the secondary glaucoma group. There was not significant difference. The number of surgeries were slightly different. So there were 2 or more surgeries in the secondary glaucoma group, and as expected, there were more high myopes in the primary glaucoma group compared to the secondary. So if we look at the results, if we look at the visual ability scores using the LV Prasad Functional Vision Questionnaire, with if you see here, the mean age, as I alluded to earlier, was comparable between the two groups, as was the visual acuity, which was 615 in both the groups. But if you look at the in the blue, look at the scores, if you see, higher negative scores are there for primary glaucoma, and higher negative scores for visual ability indicates better visual ability. So those with primary glaucoma had reported better visual ability, significantly better visual ability compared to those with secondary glaucoma. And if you see the correlation between the visual acuity and the visual ability, there was a moderate correlation, and this is expected. If you look at the vision-related quality of life scores, similarly, again, those with primary childhood glaucoma reported better vision-related quality of life compared to those with secondary childhood glaucoma. Again, the visual acuity was moderately correlated with the vision-related quality of life. In the univariate analysis, we found laterality, visual acuity, type of glaucoma, and number of surgeries to be related to visual ability, and visual acuity and type of glaucoma related to the vision-related quality of life. In the multivariate regression analysis, the predictors for visual ability, though this could explain only about a quarter of the variance, the glaucoma type, the laterality, and the better acuity, better eye visual acuity were related to the visual ability. Similarly, for vision-related quality of life, it was this glaucoma type and the better acuity were related to the vision-related quality of life, though it could explain, the model could explain just about 10% of the. So ours is a large sample size from a single center to have explored the effects of treatment of childhood glaucoma on self-reported visual ability and vision-related quality of life in children aged 8 to 18 years. And more importantly, these are interval level scores which were used from both the questionnaires, and significantly better visual ability and vision-related quality of life were reported with children with primary glaucoma than with secondary glaucoma, with comparable median acuity and age. This is comparable to the scanty literature that exists, the recent literature that has been reported. So children with glaucoma report significant problems with daily activities, especially copying from board, reading books at near, seeing markings on scale, or watching TV, reading from a computer screen. In terms of vision-related quality of life, they reported difficulty like ability to complete classwork in time, recognizing people across the room, taking part in sports. And like I said, there was a moderately significant association between visual acuity and vision-related quality of life. So not surprisingly, sharper the acuity, better is the vision-related quality of life. And this is comparable to the literature in adults and the scanty literature that has been reported in the children. So glaucoma in children requires intensive management, frequent surgical interventions, and it has a significant impact on the lives of children and their caregivers. It is important while the clinical measures are being used to follow up these children. Assessment of such impact is important in the management of children with the existing and new interventions as they are being discovered. So patient-reported outcome measures such as the LV Prasad Functional Vision Questionnaire and the impact of vision impairment in children, they capture multiple dimensions of vision-related quality of life that are not usually represented by the clinical measures that we use, visual acuity and intraocular pressure. So we believe that as novel therapeutic options for children with glaucoma are developed, it will be important to consider these parameters such as vision-related quality of life and visual ability, which are critical outcome variables in evaluating treatment outcomes. This was published in AGO 2020, and thank you very much for your patient listening.
Thank you so much, Dr. Vijay, for touching upon a very, very important topic. Any comments from our panelists? Since congenital glaucoma presents very late in our country, so the situation must be very different in Europe and in the.
Yes, thank you. I mean, we published something similar, and one of the papers you quoted there, and I think it's just a very important thing to take into account the effect it has on children, and not just children but their families as well. And we found that the quality of life of children with glaucoma was similar to children with treating for childhood cancers and leukemias and having organ transplants. So the quality of life scores are very similar between glaucoma and all those other difficult diseases that children have. So I think congratulations on looking into it. And it's something we need to bear in mind when we're treating not just the intraocular pressure, but taking all the other psychological effects into account with the family as a whole. Thank you.
Thank you very much. So it's like I said, it's so important to look at the impact it has on caregivers, because usually the child is a very young infant and these are young parents. It's usually the first child. So the parents go through a hell lot of emotional issues that the journey, and they don't see the entire lifespan at that time. So I think some hand holding is required. So if you have a group of at least a couple of people in the team that they can talk to, so that those issues are taken care of, then it indirectly impacts the care that they provide to their children. So the compliance, the adherence to treatment, all that falls in place easily.
Thank you so much. I think Dr. Sushmita will be sharing Dr. Sirisha's talk, and Dr. Sirisha will present the paper.
Yeah, good evening, everybody. So this is a paper that was published in this year, where we looked at the long-term outcomes of Ahmed glaucoma implantation in eyes with pediatric keratoplasty. Next, please. This will be the outline of my talk. So I'll just start with a case example. A child presented to us at 1 day after birth, had grade 5 corneal edema, and so this child was operated at the age of 1 month, and post-operatively, when we reviewed the child, the presentation showed corneal haze in both the eyes, and there were some infiltrates present in both the eyes. Next, please. Yeah, so the corneal ulcer showed organisms that grew candida, and there was a birth passage infection for the mother. Next, please. So this child was treated appropriately with medications, and we found that there were the eyes scarred with corneal scars in both the eyes. Next, please. Yeah, so this was the kind of vascularization that was seen. And so at this time point, post PK 3 months, the right eye was phakic, left eye was aphakic because the child had a perforated corneal ulcer in that eye. Next, please. So you actually see the discs were quite healthy in the right eye, and left eye had some amount of cupping, which was a hazy view because of the corneal edema, because left eye had raise in intraocular pressure. Next, please. So the pars plana tube was implanted in the left eye, and following which the intraocular pressure is controlled very well. And with 2 medications at 1 year, the pressure control was quite good. Next, please. Yeah. So if you look at the eyes with primary congenital glaucoma in our country, as well as in certain Middle Eastern countries, you realize that the primary congenital glaucoma presents quite severely with the presence of severe corneal haze. Next, please. And pediatric keratoplasty it becomes mandatory in these patients. If you look at the publication that came from our country, primary congenital glaucoma with needing a pediatric keratoplasty forms one of the most important indications for keratoplasty in children. Next, please. So if you look at this panel, many of these eyes will not see the light of the day without a keratoplasty, and several of these children actually tend to see and see well with a pediatric keratoplasty. And many of them also have significant raise in intraocular pressure, and secondary glaucoma is not uncommon in these patients requiring implants. Next, please. So there are several challenges to do implants in children, where there is thin sclera, a large eye for the orbit, a growing eyeball where the dimensions of the tube will change with time, problems of eye rubbing in children, and also problems related to hypotony, especially with the non-valved implants. So that there are additional challenges with multiple steroids and long-term need for steroids in these kids, and many of them being steroid responsive as well. Next, please. So with that in mind, we evaluated the outcomes of AGV implantation in eyes with pediatric keratoplasty in our institute. Next, please. So the sample size was 28 eyes of 25 children and performed by a single surgeon. Next, please. We included those eyes with AGV post-keratoplasty in children less than 18 years with a minimum post-operative follow-up of 6 months. And primary outcome measure was survival of AGV, and we also looked at the corneal graft survival over a period of time. Both adult and pediatric implants were used as was deemed necessary. Next, please. Statistical methods were appropriately used, and Kaplan-Meier survival analysis was used to look at the cumulative probability of success. And we also looked at the risk factors. Next, please. So if you look at the median age at surgery was 2.5 years, and majority were primary congenital glaucoma. And second, in terms of the disease or the eyes with anomalies, the eyes with aniridia, sclerocornea, and CHED. The number of keratoplasties prior to AGV were 1.4. So mean number of keratoplasties were 1.4. And from the duration following keratoplasty, implants were done following a mean of 1.7 years.
And all of these patients had previous glaucoma surgeries. Next, please. So the post-implantation, there was a significant reduction in intraocular pressure at 3 months and 6 months. And the number of anti-glaucoma medications also significantly decreased. There was no significant change in the post-operative visual acuity at 3 and 6 months compared to the pre-operative values, which was encouraging. And the duration of follow-up following AGV implantation was 3.4 years. Next, please. Next, please. Next. So with a mean follow-up of 3.4 years, the probability of AGV survival was close to 93% at 1 year and 81% at 5 years. Next, please. The probability of graft survival was quite good. This was very encouraging, which was close to 96% at 1 year and close to 78% at 5 years. Next, please. What was important was we never had any patient with tube erosion or implant exposure until the time of follow-up. While this is a huge problem with time and we have to keep evaluating them, the major complication that was seen was graft-related infection, which was noted in close to about 30% of eyes, which is a major issue because with the thinning of the, with the loosening of the sutures, graft infiltrates is a major problem. Until all the sutures are out, one can never be comfortable in these eyes. One eye had a long tube with a tube corneal touch that needed to be trimmed. So tube corneal touch is something that is an issue in these patients. Next, please. So what was encouraging was, until then, the publications in literature showed that the long-term success was quite low with a pediatric penetrating keratoplasty and implants, and the complication rates were quite high. This was a study by Al-Thorak et al., where the success rate decreased quite significantly, especially with related to graft success. Next, please. And this was one more study that was published from India, where Dr. Shanta's group had published this. So where they had looked at the use of AGV in the management of pediatric glaucoma, they had divided them into 3 groups. The group 1 included the primary glaucomas and those with ocular anomalies. Group 2 in glaucoma in aphakia and pseudophakia, and group 3 had other diagnoses. And the group 3 actually had several of them with post-penetrating keratoplasty glaucoma. And when they looked at the category of diagnosis, those with post-keratoplasty glaucoma was a significant risk factor for failure. Next, please. So compared to that, our results were good. So I would like to acknowledge the fact that the pediatric corneal surgeons are extremely meticulous in following up these patients. I think the success of an implant surgery depends upon how successful the graft is. So the way they follow up the patients, whether it is with regards to the medical management or the way they follow them up with regards to suture removal and systemic immunosuppression that they use. Cyclosporin is something that they use regularly along with local tacrolimus ointment. So this is something that was published in the paper as well with the recommendations as to how to follow up these children. And also the mothers being very, very meticulous in following them up. They use a magnifying lens to examine the child's eye every single day, and any dot infiltrate that they see, they start the topical antibiotics immediately and report to the emergency services. So these are some of the things that our corneal surgeons do to take care of these pediatric grafts. Ours was a retrospective study with variable follow-up. And to summarize, next slide. So AGV survival was quite good. And like I said, what was encouraging was the graft survival. Graft infections, despite all the care that we take, are a serious issue and that needs very, very close monitoring. Refractive correction and amblyopia management are very important in these children, and lifelong follow-up is necessary. This was published in Ophthalmology Glaucoma in 2022. Thank you so much for your patient hearing.
Thank you, Dr. Sirisha. Any comments from panelists? Any comments about the size of the implant used? Because I think we usually use adult size implant for pediatric glaucomas.
Yeah, so what we do is, for me, the cutoff is the axial length and the age of the child. So if the axial length is 21 and beyond, of course, we use an adult size implant. Otherwise, the younger children or those with smaller axial length, we use a FP8 implant. And we also, though the number was very small, but then what we also looked at was, we looked at the outcomes of those with FP7 versus FP8 in this cohort also, and we did not find any significant difference in the intraocular pressure control.
May I ask about the thresholds for outcome? I mean, intraocular pressure can have a 21 threshold or 18 or something else, and then the results will be different. And the same question applies, or I would like to ask for the corneal graft. How can one measure the outcome, the clarity of the corneal graft? How did you do that? I probably missed it, but that is for me a critical threshold that has to be defined.
Thank you for the question, Professor Gren. For the intraocular pressure control, we took the IOP greater than 5 and less than 21 millimeters of mercury with or without 2 topical anti-glaucoma medications, but without oral anti-glaucoma medications as the primary, cutoff for success. I know 21 is little higher, but in those post-PKIs in children, of course, the evaluation of disc was also done, but that was the cutoff that we took. And for graft failure, so graft failure was defined as corneal edema for 1 month or more, despite use of intense topical steroids, or an irreversible corneal graft opacity, which resulted in scarring or neovascularization. So failure was deemed as, the graft was deemed as failed if there was persistent corneal edema beyond 1 month, or there was scarring or scarring with neovascularization. A compact clear graft was taken as successful.
I really appreciate your precise approach to that problem, because we have learned that the intraocular pressure by applanation can be different from a normal eye when it comes to corneal grafts. We measured intraocular pressures by cannulation versus applanation. It turned out that there were significant differences, although you cannot do that in everybody, in every case. I just wanted to mention that there are some difficulties in outcomes, and I'm very convinced that you picked up the right thresholds to differentiate between failure and success. Thank you.
Thank you. Thank you so much.
Thank you. I think in the interest of time, we'll have to conclude this session. Thank you so much for all the participants, especially for our international guests who are joining us at varied points in time. Dr. Vinay and Sushmita, would you like to make any concluding comments?
Oh, it's been a wonderful learning experience, a wonderful evening, and I thank everybody. And we'll soon know how many attendees were there out there, and I'm sure it was well received, and at least I learned so much. So thank you so much, and I'm happy to welcome you all tomorrow morning. I know weird times again, but still we have a plenary session on Axenfeld and the competitive session of clinical challenges. So that should be another interesting session. Over to you, Vinay, to conclude.
Thanks to everybody, and we look forward to seeing you all tomorrow again. Yeah, thanks.
Thank you. Bye. Good night. Good evening.
Good morning, or whatever.
Thank you all. Yeah.
See you all tomorrow.